So good afternoon, everyone, and welcome to the third annual Fortune Brainstorm Health. Our theme this year is, we have a missing mic here. We have a jam-packed, our theme this year is the Fortune Leadership Summit, reframing the health agenda. And you guys are not, that's not an accident. You're all here for a reason. Each one of you is a leader in healthcare. And over the next couple of days, we will explore and reframe the agenda. We have a jam-packed couple of days of incredible discussions and on our way through the closing interview, so I hope you all stay for Kevin Durant, the four-time NBA scoring champion and star of the Golden State Warriors, and we all are very excited for an incredible conversation. Tonight, of course, we have Tony Robbins, which is going to be an amazing conversation as well. And with that, I'd now like to introduce my two co-chairs, the dream team of Fortune Brainstorm Health, the incredible Dr. Agus, who has been my partner in bringing Brainstorm Health to life from the very beginning. He's a physician and New York Times bestselling author of 3 books, CBS News contributor, the recipient of numerous honors and awards. He's a professor of medicine and engineering at USC, as well as the founding director and CEO of the Lawrence J. Ellison Institute for Transformative Medicine. And we are so fortunate to have his expertise and guidance on the team at Brainstorm Health. Last year, we were delighted to announce that Arianna Huffington would be joining us as a Brainstorm Health co-chair. And this is Dave and me proposing to Arianna, as you can see. And you all know Arianna as the woman who put the front page on the internet. As the co-founder and longtime editor-in-chief of the Huffington Post, she's written 15 books, 7 of them raging bestsellers, and her new company, Thrive Global, is intent on starting yet another revolution. This time bringing wellness in the workplace and showing real benefits for both employees and a company's bottom line. And I can't tell you how fortunate we are to have her insights and passion taking Fortune Brainstorm Health to the next level. Now, please welcome Dr. David Agus and Arianna Huffington to the stage for an overview of where we stand at. We're doing the slow handshake here. Hey, please sit. Okay, we want to frame the agenda for the next couple of days, and we thought, we can't just dive in, right? So we have to have some big picture sentiment to get us started. And I wanted to talk about
What's wrong with diving in?
Well, I guess we could dive in. We tried that last year. So I wanted to start with data, which is the cover of our Fortune magazine, this big data revolution, which I hope you've all seen lying around. It's really the centerpiece of what's happening in health and technology now, and this ability now to harness that data and to make sense of it is important. And then Arianna said, the theme of this is the Leadership Summit, and we really ought to talk about what it means to be a leader in this space.
Because this is an amazing inflection moment. And by having all these amazing people, amazing leaders here, we can actually not just reframe the healthcare agenda, but build a community where we can keep working and talking and getting things done after the conference ends tomorrow. And as you know, for me, what's exciting is that now big data can empower each individual to take charge of their healthcare, but also to recognize that big data alone does not drive behavior change. And that's why during these 2 days, we're going to also address the big picture questions, including death. Death as a way
We're going to answer that last, though. The death comes at the end.
All right. Death, just to show
right.
how a perspective on death helps us live our lives in a healthier way. We are going to have Kevin Durant speak about how he uses his sleep, recovery time to improve his performance and walk us through his stats. So new role models, big picture questions, an emotional connection are all leading towards behavior change, and big data help us get there.
Dave, can big data cure a rib fracture?
No.
Okay.
It's an amazing thing if you look at the people in the room. And I think one of the things that I've learned from doing this with you for 3 years is that there's no one company that will win. I mean, one of the things is we all have to work together. And so there's a continuum in healthcare. And whether it be the last mile, the middle mile, the first mile, we all have to work together. So the hope is in these 3 days, each of you start to meet collaborators. Deals come out of the hallways, deals come out of the talks here, and that together we can make a difference. And one of the problems in health, as Ariana alluded to, has been engagement.
Yeah.
Right? How do you can build the greatest product in the world, but if you can't build repeat user among the consumer, it ain't gonna work. And how do you get them to see the metrics that are gonna get them improved? And so I'm excited to get the collaborations and the talks happening to try to make some progress.
And we're going to see the evidence of the fact that the balance of power is changing. As you said, the balance of power is really going more towards the patient, who's the center of this data universe. And she hopefully will be able to look at all of this data that's coming out of her life and make sense of that in a way that will allow her to take that next big step that benefits her.
And ideally, what we want to discuss over these 2 days is how can we put not the patient in charge, but the individual before they become patient.
Right.
We want to go upstream. We want to address stress triggers before they become symptoms. We want to look at how can we change our lives and our choices so that we can prevent a lot of the diseases that we're now dealing with, because as you all know, 75% of healthcare problems and healthcare costs are preventable and stress related. So this is kind of this amazing moment when we have all this power, but also we need to look at some of all the wisdom to complement the big data.
Right. So all the technology in the world isn't going to change your outcomes if you're still smoking and you're still sitting on a couch all day and you're not getting enough sleep.
Well, I mean, hopefully it's deeper than that. And hopefully, the big data revolution is going to start to identify things all of us can do. I mean, because the key is the prevention, right? I mean, put me out of business. I mean, I'm a cancer doctor and I don't want to see patients anymore. And more than half of cancers are preventable, yet we're not doing it. And I think much of the responsibility is going to fall toward the corporation. And that's what we keep forgetting, is that corporate change, to get normative behavior change, you need leadership, and corporations are providing the leadership in health in today's world.
So we actually started this conference with an eye towards the idea that business, the big business, was going to be the driver in this, that business was the vehicle for social change in a lot of areas, but particularly in healthcare, because they were footing much of the bill for this stuff. And you, Ariana, you've created a whole new enterprise based on trying to get businesses to think differently about their own healthcare costs.
Well, because what we are finding at Thrive with all our different corporate clients is that they are recognizing the connection between taking care of the well-being of their employees and the bottom line. These are no longer soft, fluffy issues for HR. These are actually now touching the CFO department because they affect attrition, they affect productivity, they affect engagement, they affect healthcare costs. And that's what has changed.
And so that's why we see JP Morgan, Chase, Amazon, and Berkshire Hathaway moving to form a partnership, because this is something that fundamentally affects their bottom line for a long time to come. It's why we see all of these new mergers and partnerships, as we've written about in the magazine, but obviously CVS Aetna and Express Scripts Cigna, and all of these things are moving because this is so fundamental to their business into the future.
Well, I mean, obviously, we've become a mature industry. Warren Buffett's interested in what we do. That's pretty cool.
Yeah. I'm not so sure he's interested in what you do. But I'll buy that. We'll just let that one pass for a while.
But also, as we've discussed many times, in fact, one of the best things about preparing for this has been all the breakfasts and meetings and calls that we've had. I'm going to miss them. We have to start working for the next one right away. But during all those times, we looked at how human beings change behavior.
Yeah.
Big data is one component because it gives us power over information, but then stories. Human beings change through a combination of data and storytelling, a new narrative about their lives. And bringing all that together in our different panels today, I hope will lead to the kind of collaboration that David alluded to, which we think is the only way to really change outcomes.
So technology that can integrate this kind of storytelling and the big data analytics and have it be accessible to everyone on smartphones, with storage of our data in the cloud and instantly accessible. This is a future paradigm that we're all working for. You mentioned the fun that we've had with our meetings and our late night dinners and breakfasts and whatnot. I want that idea of community to really spread out here. We started this 3 years ago with the idea and the express mission that we would form a community. I just saw Sue Desmond-Hellman, one of my personal heroes, and she asked me, what do you hope to accomplish from this gathering? And, the first thing that came to mind was this idea of community, of building a group of people who come from very different walks of life, very different sides of the healthcare continuum, as Dave said, and working together to form a new paradigm.
And also, we want to encourage you all as much as possible to put your phones away during the sessions. In fact, we have provided little phone beds outside. I don't know if you've seen them. There are charging stations. You can
So our phones can sleep together?
Yes, your phones can sleep together. That will be the beginning of collaboration. This is a little product that Thrive Global launched. If anybody wants them, you can take them home at the end of the 2 days. You can put your phones under a little blanket, tuck them in, and while you are concentrating on all these important conversations, your phones can be fully recharged when you go back. So, it's one of the things we're going to be discussing, our growing addiction to technology and our phones, and what can we do about it.
So whenever we begin one of these kind of conversations, it always gets a little pie in the sky. We all talk about the power of technology, the power of behavior change, the power of the consumer, everything in our pocket. What is the reality check? Take me to the dark side, Dave. I count on you to always do that. At the end of this, what are the barriers that are going to actually stand in the way? What is the one thing we're going to say that this is not what consumers are going to be able to do?
There have been dozens of startups in healthcare, as we've all seen over the last decade, and almost none of them have worked in the grand scale, because adoption at a consumer level is difficult. Right. It's so hard to get you to think about something today that's going to affect you in 10 or 20 years.
Right.
How do we get behavior change to happen with a time lag for disease? It's very difficult. At the same time, how do you make a business model of it? The business of health is treating disease. We want to change that so the business of health is health.
Yeah.
And that's going to be a radical change to the system, but it has to happen and it will happen.
But the reason I'm optimistic is that the conversation has changed. Mm-hmm. First of all, this conversation about health and wellness in the workplace has gone from the health magazines to Fortune, to the Wall Street Journal, to ESPN. Right. It's really become part of the mainstream, and that's very significant. And also, you can have your Apple Watch tell you your heart rate variability and tell you your blood pressure. So you have a lot of data coming at you, which then you can actualize to bring about changes, which, as David said, are not easy. But at least a lot of good things are happening to make them more likely.
We've had a reductionist view of the world historically, right? You take this to lower this, or you take this to correct this number. And what we're seeing is that we're a complex system. The paper came out today in Nature. It is the freaking wildest paper ever. 25% of the drugs on the market today that are non-antibiotics affect our microbiome. Mm-hmm. 25% of drugs affect our microbiome. So all of a sudden, here's a new complexity that a blood pressure medicine may affect your microbiome, which will affect what foods you absorb and your lipid levels or your sugar levels. So all of a sudden, there's a complexity. The only way around that is these large data and outcome studies, which many of you in your companies are doing. So it's a staggering time, and we never had this power till today, but it's here.
And do you see a time when consumers really will take charge in the way they do in other parts? If I go and rent a car, I really want to make sure that I get the car I want when I want it, and if not, I'm never going back there. Do you think you do?
People don't rent cars anymore.
They don't rent cars. Oh, that's true. This is a totally different world.
Uber.
That's right. But do you see a time when we are going to have consumers feel just as empowered and have the access to the information they need to make decisions? Because a lot of times we don't pay for those decisions in healthcare. How do we change that?
When you checked in today, you got a piece of paper that gave you a free BRCA or breast cancer susceptibility test with color genomics.
Yeah.
So all of a sudden, right, the consumer can do this themselves and know whether they're going to have a disease, breast cancer or ovarian cancer, that's somewhat deterministic.
Right.
That's a shift in power. And I believe in the responsibility of the individual, and I think we have to go there.
Fantastic. All right, so you have an exciting moment over the next 2 days to talk about all of these issues, and I hope you'll all let us know where we come out at the end. Please let us know what you love and what you don't, and we'll have plenty of time for questions. Thank you very much. Now we'd like to recognize our exceptional partners who have made this event possible. And I mean that, profoundly. Our founding partner, IBM Watson Health, who really, from the very beginning, believed in this message and has encouraged us and pushed us and made it as expansive as they can. Our gold partners, Abbott and Herman Miller, and our silver partners, City of Hope and Parexel.
We have no bronze partners?
And just a friendly reminder about, you guys go off. I've got a few little bit of pieces to do. I'm sorry. You can come with me if you want. And just a friendly reminder of our media policy. What is said on stage at our concurrent sessions is on the record and ready for reporting, blogging, or tweeting. But what is said at the dinner table or over a break or in a walk is private. So unless you both obviously agree otherwise. And we will be active on social media. So please use our hashtag, our Twitter hashtag. That's hashtag BrainstormHealth. And the Fortune Brainstorm Health app can be downloaded. If you haven't already done it from the App Store, it's very cool. You can actually email each other and form that community. Or on Google Play as well, to ensure that you'll be up to date on all of the important changes in sessions if they're happening at the conference. And we have some extraordinary panels on the stage over the next 2 days. But at Fortune Brainstorm Health, we have the benefit that few other conferences have. Everyone here is an expert in some way, and we've seen that already in our opening lunch. This is, as I said, an invite-only crowd. We know you know your stuff. So we really hope you'll all participate. So think about questions. We'll have virtually every session will have questions and participations. We'll hope you keep that short. And our moderators will be basically opening most of these sessions to Q&As. And so please make yourself known if you've got a question. Starting today, all attendees should have started receiving a complimentary subscription to Fortune Brainstorm Health Daily. I hope you all were already reading it anyway, but if you're not, this is a newsletter that Fortune publishes every day covering the intersection between technology and biology. And most times it comes out before 6 p.m. And so you really get your day's news right on time. We'd also love you to contribute ideas that you want to highlight in our newsletter. So please email me at clifton.leaf@fortune.com with your ideas. Now, before we move on to the rest of the program, I want to draw your attention to something you may not have noticed, the comfortable ergonomic chairs that you're sitting in, compliments of Herman Miller. And here to show you how to customize the fit, please welcome Herman Miller's Director of Product Development and Management, Healthcare and Education, Joel Van Wyk, to the stage. Thanks, Joel.
So you might be wondering, why is a furniture company sponsoring a healthcare conference? Well, for 50 years, Herman Miller has been working with our healthcare customers to create great environments for people to work, patients to heal. And we believe that one of the ways that we can help our customers is thinking through the built environment and wrestling with how can we create spaces that are designed to change, and how can we give everyone a really comfortable chair. So to that end, I'm going to walk you through the adjustments on this Aeron chair. So the first thing I want you to do is, with your right hand, reach down and find this lever right here. That's going to adjust the height of your seat. So you see you can go all the way down, take some weight off it, come all the way up. So what you want ideally is you want your feet flat on the floor, and you want your legs to be, your thighs to be parallel with the floor, your knees at a 90-degree angle. How's everybody doing? All right, next we're going to switch over to the left-hand side. So I want you to reach down and grab the fat part of this knob right here, and I want you to rotate it backwards, and that's going to release the back. All right, back to the right-hand side. This is the workout portion of the meeting. Right. This large knob in front, you can turn it forwards to increase the tension or backwards to release some tension so that you get just enough resistance in that back. Okay, so if you like to sit up nice and straight, crank it forward. If you're like me and you like to pretend that you're an astronaut, you can crank it backwards a little bit. All right, last adjustment. The height of the arms. You see these levers in the back of the chair? If you flip them forward, they'll let you adjust the height of the arms. So you can get them to a comfortable height. The rest of the adjustments on the arms, you can just be done manually. And then finally, if you need a little bit of sacral support or lumbar support, you can adjust this knob in the back. All right. Hopefully, I've helped you maximize your seating experience this week. And if you have any questions about these chairs or any of the furniture that's in our spaces, please don't hesitate to let me know.
All right, we move very, very quickly forward. Now, before we move, I'm sorry. So thank you, Joel. Thank you very much. Last year, Fortune named our first guest as one of the top business leaders changing healthcare, a true corporate innovator, and one of the most forceful advocates calling for change in corporate culture, focusing not just on the bottom line, but also on the wellness of employees. The fact that he's also the CEO of one of the country's largest health insurers makes that message all the more compelling. And to talk about how the recent CVS-Aetna merger, which I mentioned before, affects the overall U.S. healthcare system and what the future of that healthcare system is, please welcome the chairman and CEO of Aetna, Mark Bertolini. Good to see you.
Good to see you.
So you have a front row seat to one of the biggest changes that are happening in healthcare today. Mm-hmm. How did this happen? You know, I know you had conversations with Larry Merlo, but before that, you said, what were you looking at that needed to change?
Well, if you take a look at how people think about their health today, when you talk to them about what matters, they never describe themselves as a disease. Mm-hmm. I'm a spinal cord injury survivor. I never describe myself that way. But I have limitations that affect how the life I want to lead by virtue of my spinal cord injury. So if you could start a conversation with people that said, what is your problem? And said, you know, what is it about your health that gets in the way of the life you want to lead? And then from that, develop a set of alternatives for them to pursue. And then look at the barriers for each of those alternatives. You have an opportunity to engage the individual. Because unless you're talking about their alternatives and their barriers, you're really not going to have a chance to engage them. And that's the problem with population health, which we were talking about 5 years ago, is everybody's part of an average population. Let's all make them look the same. Here's the ideal health status, instead of personalizing the health to each individual.
And so where do we do that? Because you, as you once told me, you spend about the average person spends about 20 hours a year in the healthcare system. You know, that's in the doctor's office, in the clinic, in the hospital. That's an average. And out of that, if you figured you sleep 7.5 hours a day, 7.5 hours a night, I hope, rather. Yep. And so if you figure that's about 6,200 hours of waking time, 20 out of 6,200 is 99.67% you spend outside of the healthcare system. Right. And yet that is where that's where we put all the burden on that time.
Two very interesting issues. Number one, we've had the second year in a row of life expectancy decrease in the United States. We have an opioid epidemic where we consume 80% of all the opioids produced in the world as an American public. And we now have a population that has 60% of their life expectancy determined by the zip code that they live in versus their genetic code, and only 10% by the clinical care they receive.
Yeah, it's incredible.
So you've got this huge vacuum, and on the other side of it, we now have price arbitrage in the system. HCCI just released some data that showed for the last decade, healthcare utilization has gone down in every single category except for drugs, which are up 1.3% on an annual basis. And yet overall costs are up 30-some%. What is it? It's price. So the price arbitrage now with the healthcare system makes it worth to make the investments in the community, so nobody has to use the healthcare system, which is counterintuitive to benefits as an insurance company.
So we're using 1% less health care in general, but it's costing us 30% more.
Right, and that's price.
Yeah. So now the story of how you started to study these social determinants of care, obviously you had your own experiences, but you were giving grand rounds with Sir Michael.
Columbia University was Sir Michael Marmot, so that was kind of intimidating. And so I needed to know something about it, and the research that I did to find out about it said, wait a minute, it was like, you know, I'm Italian, why do Italians have flat foreheads? It's like, oh my God, why haven't we thought of this? And why haven't we focused on this? So we started doing work in the communities, and we've now launched a thing called the Healthy Cities and Counties Challenge in 50 cities across the United States and counties, focused on this issue of what can we do around built environment, services, programs, food, urban farms. We've started 3,300 urban farm beds across America in the last 5 years as a way of solving the community problem, the social determinant, versus waiting for people to show up with their warranty card to get health care, which
So
is
insurance, your insurance business is walking around giving people warranty cards.
We sell warranties, right? We sell warranties.
your
When you get broken, show up.
Do your shareholders know you talk like this about your company?
Yeah, they do.
Okay, all right.
Hasn't hurt our stock price
No,
yet.
that's not hurt your stock price.
Yeah.
So, so your mission though is to move the engagement to the other 6,200 hours that we spend somehow to move that out. And so, how does this partnership with CVS, this merger happen?
Well, I would don't think about the store. Think about the connection between the provider community and home. And if we can, through price arbitrage, do more in the home and more in the local community, we need to have a demand model that understands it. Mm-hmm. And then we need to build a supply chain, some of which could come from a CVS store. But what you're in essence building is a marketplace in the community around health. It looks like Amazon, just purely for health. And you could pay for rides from Lyft. You could bring food to people's homes. You could do light construction on homes like ramps for a lot cheaper than just one ER visit a year.
Wow.
Right? So why not spend that money? Why not eliminate benefits as a notion in health insurance, which is to prevent people from running wild in the world with their warranty card?
Right.
And just say, you know what, we're going to do what we can in the community to help you by understanding demand in the community, demand in the home. We've got all the devices to do that. We're going to build a supply chain, and that supply chain is going to provide services to you at a better cost and when you need it. And it's about you. Then you look at the provider community, which sends people into the world 99.6% of the time, all assuming that we're going to do exactly what they told us. But what we know is that when we spend that 15 minutes with a doctor every year, we lie about 75% of the time about our diet and our exercise. Oh yeah, doc, all over that. My doctor one time said to me, well, then why are you 20 pounds heavier? And he pulled out the wine glass. He said, you tell me you have two glasses of wine every night. Draw a line on the glass for me. And when I did, he said, you're drinking 5. Stop it. And so it's this notion of what is it that we can do to help the provider community. So instead of taking patients away, what if we were their open source PCMH, patient-centered medical home, in the community where we said to them, when you want a patient to get follow-up, just send them to us. We'll figure out the rest for them. We'll just do it for them.
Now, but there's a social compact that has to happen. I mean, the patient has to agree to a different set of rules than we've seen in the past. I mean, more data access, basically, as you say, you want to create a new relationship that says, hey, surrender all this stuff to us and we'll create a plan together.
The only way you get permission to get the data is to use it in a way that matters to them. Mm-hmm. So you got to reverse the logic. And you have to say to individuals, tell me what your problem is. Right. You've got pedal neuropathy as a diabetic. If we get your diabetes under control, and we say, hey, you can run the 5K at the senior center next year, and you've never run an inch in your life, unengaged. But if you say to them, what is it about your feet that bother you? So you have to have a natural language processing capability to say to people, what is it about your feet that bother you? Well, I can't walk to the senior center anymore to play cards twice a week. Or I used to take my grandchildren for a walk in the park. Right. That's where you engage them. You say, well, if we get your diabetes under control, your feet will work again and you can do that again. Are you in? But we need this data to do that. Will you let us have access to that data so we can help you? Completely different conversation than saying, dump all your data to me, we're going to put the wizards on it, and we're going to spit out information for you that's going to cause you to change your behavior.
And you talk a lot about this thing called the next best action. What do you mean by that?
So for each individual, it's now possible for us to look at their current status, look at their socioeconomic factors, their zip code, the devices they use, and say to them, if you do this thing next, it's going to move you along the path of what you want to accomplish with your health. So the team's been talking to me about this for about a year, and I said to them, okay, well, show me. And we have these what we call member journeys or ideas of how people could use it. 44-year-old type 1 diabetic, 7.3 hemoglobin A1C, under 7 is good. We can give them 1 or 2 next best actions. You need to get your hemoglobin A1C checked more often because you're a data geek. And if you do 10,000 steps a day versus 8,000 steps a day, we can get you to 6.9. You're in the green, you're good. And when you accomplish that, give them the next best action. And so you're feeding them information that says, here's what you can do next to be better. It's about me, it's about my case, it's my data.
So I just want to give some background on you. Since you became CEO, just so you know, because this is Fortune magazine, and I need to talk about your stock, the total return on your stock is beaten the market by 3 times.
Right.
I mean, since you become CEO, it's during a relatively robust period for the stock market. You don't talk like a CEO. You say things that I would imagine would scare the bejesus out of your shareholders. And part of what you've been saying, at least in various conversations, is that the current model cannot survive. And so this is what sort of threw you into this very aggressive merger.
Well, the capitalist model of today says that we should manage to an earnings number that then makes the street believe that we have a going concern that they can get a return on. That's not the model. The model is about business fundamentals. What are we doing to invest in our business fundamentals so that we have a consistently good product or valuable product that the market will continue to buy? And when you have that, then the earnings come out of the machine. You don't manage the earnings, they come out of the bottom of the machine. And if you run your business that way, the earnings will come. I've never once worried about where the earnings were coming from. I've worried about the business fundamentals, and in our business, it's people, and investing in our people was the most important thing we can do. So I think every business, whether you're for-profit or not-for-profit, well-run not-for-profits still make a margin, and as the sisters of the Daughters of Charity, now the Ascension Health System once said, no margin, no mission. And so a well-run not-for-profit does as well as a well-run for-profit. The only difference is the for-profit pays taxes.
So I want to get a question in here while you're thinking of it. Please raise your hand, and we have mic runners will come, and it'll make it easy. What is the next move for, let's say this merger goes through, and maybe you don't want to talk about it until anything happens, but I don't suppose you're done yet. There's more integration that goes that sort of chases this model that you're talking about.
Well, all these ideas are great ideas. They're absolutely worthless without execution. So you have to, it's the basic, you have basic science, then you have applied science, and you have commercialization. And the step from applied science to commercialization is always the hardest.
Right.
And it's the ugliest work.
Yeah.
Because it's easy to talk about it. It's really hard to actually make it work. So when you get into the world with, data and insights and all these things for people, you have to engage them where it matters to them. That's a humanistic approach to using data and understanding how they can be engaged and buy into what it is you're trying to do with them. It makes them sticky.
Yeah, we've got a question over there.
Yeah, hi.
Can you identify yourself too?
Yes, I'm Craig LaFay from RTI International. We're a nonprofit research organization. I really appreciate the comments you're making about the patient-centered, but particularly this question of trying to figure out what's the problem the person has that the data can help them solve. And I've been on that track for a while myself, and I find that with a lot of experts, I do a lot of work in public health where I think you can start personalizing things a bit if you start thinking about marketing and not just universal application of principles to different issues. How do you try and bring people around to the idea that maybe it's not the data that drives behavior change, maybe it's understanding the people and their problems first?
Great.
So great question. It's the biggest struggle any CEO or high-level operating executive experiences. It's this idea that, you've got a great idea. Boy, this sounds really cool. Show me. And then you have to have the patience. I always like to say CEOs need to be unrealistically expectant but patiently tolerant of progress. And so you have to push the team, but you have to keep saying, show me, show me, show me. And your role as a leader is to provide the next insight to say, have you thought about this? So we're rolling out next best actions this March. And it's going to be a big deal if we get it right. And it's going to be part of our partnership with a lot of other people that we're doing business with. And so this next best action, I said to them, so what are people going to just is it going to ring in their ear? Is it going to fall from heaven like the voice of God? I mean, what's going to happen? Well, we had to create pods of teams with thousands of patients in each pod to work with them to understand what it is about the preferences they have for receiving that information, what kind of help do they need to eliminate barriers to be able to pursue that. I often remind people that people buy Peloton bikes, and the people that buy Peloton bikes, the vast majority, don't look like anything like the people in the Peloton commercials. But the barrier is they want to get fit, so they don't want to go to the gym, so they want a Peloton bike. Brilliant. That's an insight. So how do you bring that to market? And so you have to have this constant set of meetings, and you have to sit and listen, and you have to let people share, and then you have to give them insights, and then they have to go out and try it, and they have to come back. And most CEOs, most leaders don't have the patience for that. They just as soon they go away and start it, and let me know how it goes a few months later. That's the dirty work of leadership and actually creating innovation. Innovation is in that journey, those meetings and those insights, not in the big idea. And if you look at any great innovation we've had in society, there were people who, the idea isn't the same anymore than when it originally started. When Steve Jobs looked inside the first Mac and said, those transistors need to be lined up, and Johnny Ive said, well, don't worry about it. Nobody's going to see it. He goes, I'll know they're there. It created a notion about the aesthetic. The aesthetic was most important. That's the user interface. That's why everybody likes to hold these devices, because it's beautiful. And so that's the patience that you need to go through in looking inside the machine and saying, line these up. And I don't think people have the patience for that.
That's good. We have a question all the way over there on the left.
Hi there, CEO of Allergy Amulet, Abigail Barnes, also the author of An Entrepreneur's Guide to Certified B Corporations and Benefit Corporations. You once said that under the current model of capitalism, it will destroy capitalism ultimately. You've substantially raised the minimum wage for your employees. You've created healthcare programs to offset healthcare costs for your employees. And so my question is, are you seeing a shift towards a more stakeholder-based approach to business rather than one that is focused on shareholder primacy? Larry Fink, CEO of BlackRock, also made this point recently in his investor newsletter, largest investment firm in the world. So I just wanted your thoughts on, is this a trend? Are we seeing more of this?
And Larry and his folks are our largest investor. So they put their money where their mouth is. And I think there's more and more CEOs coming into the role who now have the courage to say we have a broader responsibility, not only to our shareholders, but to our employees and to our communities. And I have this notion that our ecosystems, our social and economic ecosystems, have gotten too big for our governments to manage. And so we try to get bigger government to manage bigger ecosystems, and it doesn't work. And so everything's going back to community. And what's happening is 288 cities, counties, and companies stood up and said, we're going to support the Paris Accords even if our nation doesn't. That's community. And so I think the best way to manage the kind of shift we're in is to go back to community and to build smaller and smaller governance models to help support the growth of this. Because if we don't change, I'm certain that it will be changed for us. And wouldn't it be nice if the captains of capitalism, men and women, decided we're going to change this now and we're going to make it better?
You mentioned before user interface. And when most people think of the user interface in the healthcare system, they think about the triage desk at the hospital, or they think about what it's like with the billing department at their clinic or their hospital. I mean, they don't really get a good experience from their user interface. I can imagine if Johnny Ive is thinking about this, he must be, frustrated about the design aspects of this. How do we redesign the user interface for healthcare?
You got to get closer to the community. You got to be in the community, and that's one of the reasons we put the companies together with CVS. Right. Is this idea that there are 10,000 stores within 5 miles of 80% of the American public? Wouldn't it be neat if you could just go to your local store? I mean, I've even joked around and said, we should put the soda stand back in there, and people sit at the counter and get a BLT or whatever it is you want. Peanut butter and jelly sandwich is my favorite, and and just sort of hang out in this local community and get information you need from each other. Doesn't necessarily need to be a practitioner. From your pharmacist, those sorts of things, and so that whole milieu could change, and people could feel better about having the conversation we need to have. And maybe, just maybe, if we define health as healthy people are productive, productive people are spiritually, economically, and socially viable, and viable people are happy, maybe we'd have better communities and better civility.
Nice. All right, we have 2 quick questions. Could we keep them quick here? One over here first, and then we'll go. Yeah.
Hi, I'm Yoki Matsuoka, CTO at Nest, and now a part of Google. You mentioned about bringing a lot of things distributed into homes, and tech companies can help a lot on that. But a lot of tech companies have ran too fast and then fallen down doing it really terribly in the past, as well as a lot of companies are scared to do it right and are not doing a lot. From your point of view, can you tell us the role that large tech companies should be playing right now?
The tech companies should help us understand what information we can get from that piece of technology that will matter to the member. And what happens often with the tech companies, and we've touched a lot of them over the last decade at Aetna, is that those tech companies want to sell us something. And it's not about selling something, it's about the customer experience front to back. What is it about that journey that we can assist with the technology? And then let's figure out later how to pay all the people that are part of it. But immediately comes up, I need so much per member per month in order for you to use my technology. Why? All those sorts of, so I think it's, and we're going through this work now, is defining the customer experience front to back, from the home to the healthcare system and back. If you define that, what types of technology will be incredibly useful as part of a platform to support that journey versus having it be something people have to buy. Because if we get, for every 50 basis points we change trend, we get $980 million of underwriting margin. So we'll pay for it. Just show us why it matters.
Quick, very quick question right over here. I think we have one. I'm sorry. Oh, go ahead. Very quick. Yeah.
Yeah, hopefully quick question. Love everything you've been talking about and the concept of the next best thing with patients and individuals that are working to change behaviors, and wonder how you think that plays into the mental health and wellness world, because I easily see where data and AI helps with precision medicine and genomics and behavior, but how about on things above the neck?
It's all about everything above the neck. It's all up here, right? The scariest place sometimes to be is between your own 2 ears alone, or to let anybody else in, and that affects a lot of our behavior and the way we respond to things. So you can't separate mental health from physical health. It's all the same body. It's all the same thing. And so I think our opioid epidemic is a direct result of the loss of hope on a large swath of the American public who believe they have no future. And so they've just checked out. And that's a mental health problem. It's not a physical problem.
Mark, thank you. This has been great. We have 30 seconds left. What is the next big merger that's going to happen? 30 seconds. Any company.
You mean any company?
Any company, any company.
I have no idea.
Right.
I'm not going to get. We're still in front of the DOJ. I'm trying to get one deal done.
Okay. Mark Bertolini, thank you so much. That was
very good to see you, Cliff.
I love that. That was so good. Thank you. So that question over there was not a ringer, and Mark's answer wasn't intentionally designed to bring in this next panel, but the barriers to mental health healthcare access are significant ones facing many, many Americans. More than half of adults with mental illness in the U.S. do not receive mental health care treatment. And that statistic alone is cause for concern. But mental health issues are far more common than people realize. And to discuss the ways we can improve treatment, please welcome Deborah DeSanzo, Amy Powell, and Bernard Tyson with my co-chair extraordinaire, Ariana Huffington.
So we have an amazing panel to discuss what has become the leading cause of disability worldwide. And it's only getting worse. Basically, 350 million people worldwide suffer from depression. And in the past 45 years, suicides have increased 60% worldwide. And every day, the opioid epidemic is getting worse. And yet, we continue treating mental health, with a few exceptions that Bernard is going to talk about, as though it is not somehow part of the overall health, as though it's somewhere in the corner by itself. So to discuss what we can do differently, we have Bernard Kaiser, who is, of course, the... You know, I always call him Bernard Kaiser. That would be a good name for him, but you don't have to change it. Bernard Tyson is fine. And he has not only been leading the discussion about mental health, but as chairman and CEO of Kaiser Permanente, he's already leading the way in putting this new way of thinking into practice. And that's not just for the benefit of the over 12 million members of Kaiser, but for the benefit of all of us by setting a new pathway to treating healthcare, mental health care differently. And Deborah, who is of course also our major sponsor here for the conference, thank you so much, Deborah, and the general manager of IBM Watson, working on the moonshot of changing how we provide global health care. And at the same time, she's taking care of her own mental health by meditating and being, I think, the only black belt on the panel, right?
I don't know.
Unless anybody wants to challenge that. And I'm really so happy to have here for the first time at this conference Amy Powell, the president of Paramount Television and Digital Entertainment. Among many other things, Amy produced 13 Reasons Why, which was the groundbreaking Netflix series that fueled a nationwide discussion about teen suicide and mental health. And so one of the things we want to talk about is how can we change culture in order to treat mental health differently. So let me start with you, Deborah. This past year, a lot of the discussion has been about the ways technology impacts our physical and mental health, both in all the positive ways that we have discussed, but also in the negative ways. We have the data, for example, now that teenagers who spend 3 hours or more on social media have a greater chance of depression or anxiety. So what do you think about this inflection point we're in, where as well as celebrating what technology makes possible, we are becoming much more aware of the unintended consequences?
I think it's from a tech company, so I have a point of view, and we absolutely need to watch social media and the effect that it has on our teens. I'm going to go to the other end of it, though, because it can also very much help. So in Bolzano, Italy, has more people over the age of 60 than any other city in the world, Bolzano, Italy. And of course, because of this, their healthcare costs are rising, and in Italy, the government pays for healthcare, so they have to be careful about their healthcare costs. And what they found in the aging population is that the elders are lonely. And of course, then loneliness leads to other more complicated diseases, leads to mental health issues. We've actually been able to use social media, connecting the elders together, and a community also connecting them together with their children, and using these cool Internet of Things that by unobtrusively watching, you know, did the mother get up and cook her pasta, and it's Italy, so it really is pasta, and watching what's going on, we can see patterns in what's happening. We can create alerts if something is off from where it is. But what the elders have found mostly is that by connecting them to their children that might live in another city or somewhere else, that they're rising out of there, they're feeling more connected. So it's absolutely, we have to watch the effect of social media on our children, but not throw everything out, because we see just terrific places where technology can help.
Absolutely. So Amy, since you've worked on specifically the impact on teenagers, is there something different about the impact on young people before they have actually built their own foundation, their own moral compass, their own sense of what matters?
So we produced the show 13 Reasons Why with Selena Gomez, who actually bought the book with her mother when she was about 19 years old. And they bought the book together because Selena was so aware of teenagers' pervasive senses of loneliness, of self-criticism, of bullying vis-a-vis social media. And I don't know how many of you have seen the series, but it sort of attacks head-on teen suicide as a result of online social bullying, where our lead has a photo shared of her in a compromised position and takes her life by the end of the series. And we decided to really show that scene in graphic detail, to much controversy, I will admit, but really to spark a conversation not only amongst teenagers, but with teenagers and their parents. Because one of the things that we saw kind of in contrast to this example here is that kids and their parents weren't connecting about this provocative topic, and they felt isolated from each other on both halves of the equation. So we kind of struck right into the heart of the zeitgeist and right into the heart of the controversy to say to parents and kids, talk to each other, talk to somebody, because we wanted kids to realize that their life is so much bigger than this one moment that they were experiencing vis-a-vis social media, and that no one's life was worth taking.
Bernard, you've written that the healthcare industry needs to take a unified approach to mental health, with the understanding that the mind and the body are irrefutably connected. So how have you put that into action at Kaiser?
In terms of context, what I've been talking a lot about is, if you stop and think about it, we have disconnected the head from the body in how we take care of mental health illnesses. So we have people to go to a different room in the industry, separate records. We treat it all differently. Some of that came as a result of the negative stigma of mental health itself. And so most of us have it, or 1 degree from it. It's around us, but nobody wants to talk about it. So we've been working on a multi-pronged approach. One is to deal with the stigma issue, and we call that Find Your Words. And it's right in line with what you're talking about, is showing people that there's a way to just ask for help and or just say, I have a problem. We're gathering more research and data, and you certainly have talked about data, and I really resonated with what you're talking about. The #1 killer for girls right now between the ages of 15 and 19 is suicide. The number 2 killer for young people between the age of 15 and 29 is suicide. 50%, roughly 50% of people who commit suicide never shows any sign to someone that they are thinking about suicide. It's a bad problem. So we've been working to now integrate with, inside of our system, to integrate psychiatry and behavioral health services inside of the primary care practice. And it's ironic that, especially in our situation, we can do it readily because we've always worked with a team-based integrated model. And so now just think about if you come in to see Kaiser Permanente physician, one of our Permanente physicians, and you have a knee pain, it's not unusual for the doctor to say, you know, Dr. Sally is down the hall. She's an orthopedic specialist. I'd like her to come in and take a look at this. And 9 out of 10 times the patient says, I would love that. So now you're sitting in the doctor's office and they ask you, how you sleep? How are you sleeping? I'm not sleeping well. How are you eating? I'm not eating well. Do you have a lot of stuff on your mind? Yes, I do. Do you feel stressed? All the time. So I have Dr. Sally down the hall. She's a behavioral health specialist. Why don't you let us come in and do an assessment, see where we go from here? So you build it as an integrated part of the whole practice, and you start to orientate people that the mental illness is something going on in the brain. And you start to treat the brain as an organ, which it is, just like you would a heart. And it's our hope that sooner or later we will start talking about mental health as easily as we talk about diabetes and cancer, all towards making it okay to say, I'm not okay today. And that's really what people are dealing with, the complexities of life that causes anxiety, that causes depression. It can happen to any one of us at any given time, and it's devastating not only to the individual, but also to the extended family. And so we're taking a holistic approach of how we address this, just like we have every other kind of disease that we've dealt with.
Deborah, Bernard mentioned how this is like a disease of the brain. You can measure some of the impact of what all these social determinants are having. You know, some of the things that Bernard mentioned, like sleep, like what people are eating, like how much stress are they under. That's an enormous amount of data to bring together. So how can technology help us bring all that information together in a way that becomes actionable and that can lead to behavior change?
I loved what Bernard said, where he said we're an integrated system, so we can ask these questions and send the patient down the hall. And it's not always like that. So what we see, we do health and human services in 22 countries, 170 million people, and 20% of the population will have some type of behavioral health issue, but they're accounting for 80% of the cost. And we know that if we don't get behavioral health under control, then you can't get your diabetes under control, or you can't get your heart disease under control, you can't get anything under control. So how technology can help is exactly that. When Bernard went through the questions that he was asking, you know, how are you sleeping, how's your stress level, sometimes that is not, it does not come to the surface of the electronic health record, or it doesn't come to the surface of, it might be in a doctor's note, or it might be somewhere else. And so what big data can do, what technology can do, is actually mine through all the information. Electronic health records now are thousands and thousands of pages long. What we can do is mine through all that, not only the electronic health record, but work records, other records, court records, mine through it, bring the important information to the surface so the primary care physician can see it, or someone can see it and then address it. Sometimes the data is simply there. It's there, but it's invisible. And what technology can do is help make the invisible data visible, so then you can act on it.
And then it's really the combination of data and then storytelling that can help engage people emotionally so they can do something about it. And Amy, that's where you come in. Is there anything more that can be done? And maybe you already did a lot of that to build like touch points that can touch consumers and those watching the series and help them make changes in their lives?
Yeah, it's interesting. On the first season of 13 Reasons Why, we went to Netflix and said, we're really worried that when kids are watching this show, they're not going to have an interactive resource to click a button or to automatically call somebody because you're on a platform that doesn't have that level of interactivity, of course. And they agreed, but we didn't find a solution. So we taped what we called a town hall, and we partnered with a lot of different crisis text lines to provide resources to people who were viewing. But it wasn't an immediate click. I'm watching this, I'm worried, I'm gonna hit a button and someone's gonna call me back. And those are things, we just finished season 2, we're starting season 3 now, that we've worked with Netflix to improve for the first time on their platform. The ability for users who are watching the content to have an immediate response. We've geo-filtered all of the DMAs of where these viewers are watching to be able to say, we know where you are at, and we are actually going to find somebody who's on a phone in your zip code, essentially, as much as we can be specific about that, to call you back immediately. So we're really trying to create a connective one-on-one dialogue between somebody who's having a crisis of whatever level that might be and somebody who's resourceful to be able to help them immediately. And that feels like our responsibility as storytellers, and also it's important to the people who created the show and the network that's distributing it, that we're responsible in our content creation.
Right after this question that I have for Bernard, I'm going to come to you, so I hope you are ready with your questions to the panelists. Bernard, I wanted to ask you, you have been such a pioneer on this. I mean, I remember doing an entire panel with you in Davos early on, before people were talking a lot about mental health. How have you seen the stigma associated with mental health change? Are we much more willing, when I say we, both us individually as well as corporations, to address it openly?
I am seeing a shift, and I think it's a combination of everything that's going on, the impact of social media, storytelling is very important. I think that we're not there yet, but I think people are more sensitive to that this is an issue that we have to deal with. I think in some cases it's mischaracterized when we have these kind of events that are unfortunate. And so I think there's still work to be done on how to define mental health, and it's not every time you have a particular kind of shootout and those kind of things. You know, in fact, I shared last week, I was curious inside of Kaiser Permanente, how many gunshot victims did we take care of? And so 2 weeks ago, I asked somebody to pull those numbers for me right quick. And for 2015 and 2016, we took care of 11,285 gunshot victims just in our system. And not all of those were mental health issues. They were probably domestic issues. Somebody got upset in the moment, so heat of the moment. I think as we continue to talk about it, though, our work is to create the right framework. Number one, where it's okay to talk about it. I mean, just think about historically how we dealt with mental health. We called people crazy and nuts and psycho and all of this, and we created this negative image around it. And then if you fast forward to today, all of us are dealing with extraordinary stresses in life. And part of our work ahead of us is new tools for resilience and how people deal with the realities that we are in a fast-paced society. The world is moving very fast. The news is changing every 5 minutes. Well, now every 1 minute. And there's a lot going on, and helping people to cope with all of this. And then you have this tool called the iPhone now, or the iPad, or whatever tool you're using, that the research is starting to show that people are on it almost 24/7. You wake up at night, you got to get on it. And I mean, you're trying to teach us different ways of unplugging. You tell us to put the phone in another room. Then we move into that other room. But we're making progress. And so, you know, we live in this kind of society now, and we need to, in the 21st century, continue to think about a holistic approach to the realities of how we live in today's society.
It's really establishing new rules of the road. I mean, if you think of it, the iPhone is only 10 years old. So we're just beginning to be very conscious of all the problems that were unintended, but here they are. We're seeing them and we have the data. So questions. Yes. And
Good afternoon. I'm Erin Byrne, the CEO of Gray Health Group, and I absolutely agree we need to change the conversation about mental health, really moving from the I in illness to mental wellness, with we being a community that supports the person in their quest for mental wellness. But what specifically can we do about stigma? Because all the resources we provide, if they don't feel comfortable taking that next step and they're afraid not only of the implications for themselves but their family and this younger audience, nothing will change. So I'd really be interested very specifically in what you think we should be doing to avoid stigma and change it.
You know, one of our ecosystem partners is a company called Teatros. They're actually in San Francisco. And they work with veterans, and so one of the stigmas on veterans is their mental health when they come back. And actually, again, to the opposite, and I don't know if there's an age thing, but what Teatros has done is they have created a social media platform to have veterans talk together. So there's much less stigma there. So you're in a community together, connecting veterans to veterans. They talk about their problems together. We use Watson Personality Insights and Tone Analyzer also to watch the conversations, watch the tones. We can identify personality traits, needs, and values. And then Teatros is not only creating the social platform, but also personalized cognitive behavior, treatment plans for the veterans, and it's helping tremendously. So I think you get patients like me together, or people like me together, and you can use technology for the good, use a social platform for a supportive, and this is what Teatros has done.
I think just to build on that, we're targeting large companies because you have a lot of issues with mental health in the workforce, and so I think figuring out how to get to large groups, but I also think this whole thing about being willing to talk about it and continue to promote the openness of the discussion continues, I think, to be a very effective way.
Yes. Yes.
Craig LaFay, the lead change designer at RTI International. I've been spending a lot of time with stigma as well, both with Special Operations Command, where suicide is probably the #1 issue that those troops are dealing with these days and their commanders are dealing with these days. And one of the things that I have noticed in my work with them is not just the issue of the individual stigma, and there was also the reference to the stigma that gets reflected onto the family. But because you're in the Department of Defense, you can also look at, well, what are the policies that are in place, or the institutional stigma that goes along with this? And the one study that was done just a couple years ago identified over 200 policies that in one way or another stigmatize soldiers who have some kind of behavioral health or mental health problem. The interesting thing of all that, however, was that part of the problem with the institutional stigma is no one can really define that very clearly. They talk a lot about stigma and anti-stigma efforts in the Department of Defense, but you very rarely see a definition of what they mean by those types of things. So I'm wondering what your response is to the idea of what's the institutional drivers, or the social determinants, if you like, drivers of stigma, and how do we kind of move this conversation not just from the individual and the people around them, but kind of to more the upstream drivers of some of these problems?
You know, I don't have the answer to that question, but I just want to acknowledge that's a great question. It's in our school systems as another example. It's how we deal with what we call learning deficiencies in our society. And his point is an excellent one, and it gets back to this whole thing about definitions being needed in today's time, because no one really describes what it means, but all of a sudden somebody is saying, but this is it. And unfortunately, what's happening now with the stigma, you get labeled. And that's what we're trying to address, which is the labeling of this. And the labeling of mental health is still seen as a very negative thing. And I love also the mental wellness. I have a dear friend that keeps telling me I should be talking about brain health, and I'm still talking about mental health and wellness, but the point is it creates a different kind of dialogue, and that's what we need to do to begin to put those kind of definitions around this complicated topic.
Thank you so much. Thank you, Deborah, Amy, Bernard. And this is a conversation we want to continue with you through the months and years ahead. Thank you.
Thank you.
Thank you. The borderless world, the connectedness of our planet undeniably applies to healthcare just as it does to every other aspect of our lives. We see the irrelevance of, or at the very least, the transcendence of these borders everywhere, from the spread of disease to logistics of drug development and to even the copying of intellectual property. Here to discuss the challenges of globalization and human health, please welcome Joe Almeida, George Barrett, and Mike Milken. Thank you. Hey, Joe. George. Mike. So, it's a connected world, and this is an obvious challenge to everyone in thinking about whether it is the spread of disease, as we saw with the Ebola virus, with emerging threats, whether you have global supply chains, which I know, of course, all of you do or have had in the past, or if it's a question of figuring out intellectual property and figuring out whether you can protect that in a world in which it's very easy to back engineer something and figure out how to steal it. Mike, when we were talking earlier, you talked particularly about the kind of value to society that comes out of healthcare. And I think it would be interesting just to use that as a framing device, if you would.
Well, the idea that if you can save one life, you save the world is obviously an idea, but there's an economic issue that people talk about, how much should I pay, et cetera. And I think we sometimes forget that the major growth in the world for the last 200 years has come from public health and medical research. When you think that average life expectancy on this planet was 31 in 1900, 31 years of age. Today it's well into the low 70s. That's for the whole planet. And in 4 million years of evolution, you extended life by 11 years, and now we've extended life by more than 40 years in just the last 115, 16 years. I think we don't recognize how important it is. And if you thought that the life expectancy in Southeast Asia or South Asia was going to increase by 70% in 2 generations, if you're just an investor, it would have been a great place to invest. And today, I think from our standpoint, one of the great challenges in the world now is really sub-Saharan Africa. UN is projecting in Africa as a whole an increase of 3 billion people in the balance of this century. I don't believe that's going to happen, but you're going to have 1 to 2 billion more people. And what happens on this planet, it's going to be heavily related to what the opportunities, what their life is, what meaning. And a lot of this can be attributed straight to medical research, advances, treatment that's occurred. I mean, Uganda, median age is 15. And so with a 98% probability of not passing AIDS to your children in a continent that has 2/3 of the people, it's going to be a tremendous challenge for the world to create those opportunities for them. But I think started out, we just think how unbelievable is that new drug or a new therapy can save a life. But it's created the world as we know it.
Joe, and we're seeing obviously a complete transformation of the health status of many in the developing world, where chronic diseases that we associated with the West are now very common in many developing countries. We've seen obviously growth of cancer and heart disease and diabetes, in particular in China, but also kidney disease. And these are areas that you work with. As you see it, part of the problem of the borderless world is we've exported a lot of our old, rich people's diseases to them in many cases.
Yeah, we did, and but we cannot export enough and fast enough the treatment and potentially the alleviation of pain and cure. You have chronic disease today, think about kidney, about 6 million people in the world suffering from some degree of kidney failure. And how many people are really treated? And that is the biggest thing. And the difference is the access to healthcare. So despite the fact that we can call a borderless world, it's very complicated still to provide therapy that is uniform across the globe for many reasons, one of them being significant barriers, regulatory barriers across the globe. Very difficult today to have a clinical trial that can be adopted across the globe. So that costs a significant amount of money, multiple times more than you would if you just had a globally accepted. And there is something that if there was something to be done in global health would be unification of clinical trials that can take therapies and drugs and devices across the world. And because the markets can regulate price, markets can regulate cost. What the markets are not regulating well today is the adoption of the technology because the lack of understanding how the patient should be treated more effectively in several different countries.
So I love this idea of having a common standard across various jurisdictions so that you didn't have to go and apply for marketing approval in 17 different jurisdictions or have clinical trials follow X number of rules. But another fundamental challenge is, of course, the supply chain. And when you're dealing with global companies today, particularly in something like Cardinal Health, where you have an extraordinarily global supply chain, and talk a little bit about the challenges there.
Yeah, so I mean, the conversation earlier has been about the commercial borderlessness or the absence of that. I think on the supply chain side, it is quite seamless. I shouldn't say seamless, it is quite global. It's not always seamless. It is virtually, even if you think of yourself as a domestic company in healthcare, it is very likely that you're dependent on intermediates or other products that are coming from around the world, whether or not it's active pharmaceutical ingredient for the pharmaceutical supply chain, dosage forms. A company like ours, we produce radioisotopes, or we compound radioisotopes that are used in imaging for cancer or cardiology. Those nuclear isotopes are not being produced in the US. They're being produced in the Netherlands and in South Africa and in Canada. Clinical apparel, safety apparel, is being sewn in parts of Asia. That work is not being done here in the US. And so I think even if you have commercially a business that is focused on the domestic US market, it is very likely that you're part of this global interconnected network.
Cliff, one of the things that was raised by Joe, excuse me, is we talk about global disease, pandemics, etc. One of the greatest things that's affecting the world today is the export from the United States of our food, fast food, etc., around the world. So when you look at obesity, that's costing the U.S. over $1.5 trillion a year just in chronic disease. We've now exported that, whether it's the Middle East, whether it's Asia, parts even of Europe. And so we are exporting this enormous burden to deal with in the rest of the world. For example, if you went to medical school in China 3 decades ago, you never studied obesity and you didn't study diabetes. They are on the verge of having the most people that have diabetes in the world today, and incidence of hormone-driven cancers have doubled, tripled, and quadrupled in some cities. So it just isn't the movie that we're worried about something that started in Africa that traveled around the world. The changing of the food chain around the world has dramatically changed the onset of diseases, particularly chronic diseases.
So how do we change the conversation about healthcare so that we're thinking of it as a global conversation? Since clearly it is, I mean, it's touching every part of the business, of the regulatory process, the innovation cycle. How do we start thinking about that? Because we Americans tend to be very focused on the U.S.
Let me give an example. We're working with the Indonesian government. Indonesia, as most people know, has 150, 180 million people. Islands everywhere, very disconnected population in terms of how you connect between the islands, and healthcare service is very complex. So the ability to bring people with kidney injury or chronic kidney disease is very difficult. So we're working with the government. We took them to Colombia. We run one of the most successful global pre-dialysis treatment and dialysis treatment in Colombia. Baxter has its own clinics there. We're the market leader there, and we have phenomenal success. Why? Because you can start from scratch, and we can produce and sell products from folks. If they learn and standardize the protocols, you can get much better at treating dialysis patients before they actually need the dialysis, not only saving a significant amount of funds, but also preserving the lifestyle of the patient, who can work and can do other things before going into a more invasive treatment, which they have to do either in a clinic for 3 times a week, 4 hours a day, or do it at home with peritoneal dialysis. So it is important that governments understand that there are other places that they can learn, and protocols are not explored on a global basis the same way. So treatment protocols that work in several places have significant resistance, either by the medical community sometimes or by governments in terms of adoption. So our ability to have the opportunity to show the Indonesian government and partner with them in how we're going to develop the dialysis treatment for untreated patients in Indonesia was a big deal. So there's more to be done. It's incumbent upon the companies, incumbent upon the governments to come together in a partnership to treat those very critical diseases.
I think to expand on this, if you think about my personal view, we will become a more evidence-based healthcare system. The evidence is global. We see it from around the world. So I'm sure that a lot of this meetings, discussions will be about the pure science of that. But there's other aspects to this. So for example, we have dramatically aging populations around the world. There are really varying degrees in terms of how effectively our aging populations are, what their welfare is like, whether or not they're happy, isolated, many different aspects. This is now being measured in different countries in different ways. So we have a lot to learn, and it's not just in the basic sciences, it's in the delivery of care. How do we think about wellness? How do we treat the aging population? The kinds of things that Mark talked a little bit about earlier. So social determinants are very important, and we can study other countries, and there are things we can learn.
Yeah, I'd love to get a question here, a comment. Yeah, do we have anybody over here? Okay, well, while you're thinking about, we've got one right there. Please let yourself.
Thank you, Cliff. Alberto Grignolo, par excel. I'm puzzled by the comment or suggestion that global clinical trials are a barrier, that somehow it's not possible to do them. I say that because we do dozens of them. And in fact, the regulatory barriers to doing clinical trials are collapsing everywhere. China, even 4 months ago, said they'll be happy to accept foreign data as part of global trials in which Chinese patients would also be included, and they want to see those. But Japan, US, Europe are all welcoming global trials as a way to accelerate the arrival of medicines to patients that need them. So I just wanted to make the point that A, I was puzzled, and B, there's evidence that pharma and CROs are conducting global trials all the time with relatively few regulatory barriers. So the days of blaming regulators are kind of waning, and we can blame other people now, but the regulators are no longer a chokeable neck.
I think
I don't think you're 100% there. It happens multiple times, but the data set is highly scrutinized, and the cost sometimes is prohibitive. You can do that, and we do that. We have 1,000 patients going on a new dialysis treatment for a new filter that we have, but the trial it took a while to design because to satisfy different countries. So you can do it, but it's still quite a bit of barrier, not for them to accept, but also to get paid on that therapy. So you have both the reimbursement issue, which is easily, people don't look at that as much as you look at the clinical trial, but the regulatory in general is until recently, you can approve things in Europe in a very less bureaucratic way. It's changing, unfortunately. But to get paid in Germany and other countries in Europe is more difficult. So I agree with you on the regulatory clinical trials. In regulatory in general becomes still a barrier. It would be easier if those collapsed even further. It's getting progress, but it's still quite a bit of work.
I'd like to just point out, if you look at what's occurred in India, where they've now effectively registered and identified 1.3 billion people. In much of their treatment, if we took cancer, people with advanced cancer, in many cases, don't get any treatment. Because you're going to figure out you have more people to deal with than you can afford treatment. This will open up significant treatment, and the ability to register a person for a clinical trial might take a day to get the number of people rather than a year. And so I think we sometimes forget this is a challenge in China. Many of the people with serious diseases, there is no Medicaid, Medi-Cal, other devices. They cannot even afford treatment. So those willing to participate in clinical trials in many ways is their only hope, and I think the sheer fact that 40% of the people in the world live in India and China holds great promise for much of this work.
Is there any country that's doing it right? You know, we talk a lot about the challenges in healthcare in the U.S. Is there a country that you think, you know, ought to be a model for us?
Cliff, before we pick on the United States, I just want to stress the work that we've done over the last 25 years. If people weighed the same in the United States as they did in the start of the 1990s, you wouldn't even be having these conversations. So what we've done here is we've added this enormous burden due to lifestyle from chronic diseases due to the change in weight. There was only 4 states in the United States in the early 90s that had any obesity problems: Louisiana, Mississippi, West Virginia, and Michigan. Today, all states do. So you can't really compare the U.S. because we are the heaviest, most obese country in the world. And so I think part of the discussion you've had here is if we could engage earlier, if we could reduce obesity, you might have a dramatic change in what's going on here.
I think the question also as to where it's done right means in what context. So you could very easily argue that if you were anywhere in the world today and you got very sick, where would you want to be? And the answer is right here in the United States. You could also argue that we have a problem with equity in the United States in terms of healthcare. So it's not about our capacity to deliver the finest healthcare on earth right here in the United States. It is about whether or not it's available and accessible to everyone. There are other aspects of health, and I think this is where you get the connection between, you know, do we spend so much in healthcare because we're not spending it in other aspects of life that might affect our wellness. So I think this is going to be one of those vexing problems, and it also ties to the question of culture, which is what we might accept as someone in Canada or Denmark might accept as a delay waiting for a particular procedure. An American might be completely frustrated.
It's a great point. I'd love to get another question from somewhere in the audience. Anybody? Oh, yeah, we got one right there. While we're waiting, if you identify yourself, please.
Hi, Jennifer Miller from Bioethics International and NYU School of Medicine. Do you think globalization is a double-edged sword in clinical trials? So positive things, we get to know how, in theory, different drugs work for different populations and they get access to clinical trials. And we know that patients in clinical trials fare better than those that aren't in trials in the US and globally. But on the other end, do you worry about the generalizability of the data produced through globalizing trials? I ask this because when I think about the drugs that were approved in 2012, I think just those sponsored by large companies, they were conducted in a median of 2,000 people in like 40 different countries. So how generalizable is the data from clinical trials as we continue to globalize?
Sometimes you hear that ethnicity play a role, so it depends upon the drug, but in some of the products that we design, we're a medical device and a little bit of pharmaceutical, injectable pharmaceutical company, I think a global trial is we're just doing one right now for the proving of a certain filtration of molecules into a dialyzer. 1,000 people, and if you select, you get a good CRO, you're going to end up with a good data, and the statistics are proven to be there. So it's tough to judge from the the comment that some of these drugs are 2,000 people. Some you do post-clinical trial studies and you continue to validate the data for different indications. So I think it's okay to have this approved and done correctly, and I think there is merit for the numbers that they are chosen. You have, Cliff, you had mentioned something about what country is doing right. There's a huge progress that we've been making with as an industry with the FDA. I think the FDA has moved significantly in a way that understands how difficult it was in the past. I think that in the United States, we have the advantage of having a more open FDA today that perhaps we had in the past, and it has made a huge difference. Some groups of countries in the world are going the other way. So it's tough to see that. And US has more of a consistent approach to how an approval is managed. Sometimes is less expected outcomes from other countries. So I would say I'll give Dr. Gottlieb and the new administration of the FDA some credit, and the previous one as well, for having moved the FDA to a different level and being more aligned to the interests of the patients in the country.
Yeah, I think that's where I'd love to spend, we have a couple of minutes left on emerging
Just like to comment, if I could, one second on that last question, Cliff. One, we don't know by taking tests all over the world whether people have the same microbiome. So we don't know necessarily how people adjusted because they might be substantially different from one another, not necessarily in DNA, but in their microbiome or other issues. So that's one challenge. But I think one of the things I would say about these clinical trials around the world, if you step back and look at China, what could be a challenge to the rule of the current president of China? Not dealing with medical problems. They have far more than anyone else. The environmental that's occurred, you have to solve this issue. Great companies like Cardinal and Baxter and others ultimately will have great opportunities in China because you're serving the people. The same thing in India. So you're going to see dramatic changes and also the change in the cost curve of how you're going to deliver them. But there is no future for many of these government leaders, no matter how important they are today, if they can't solve the healthcare problems in their own country.
Yeah. The last question is emerging threats. You know, what we saw with the response to Ebola, the WHO was criticized. Part of the challenge was it's difficult to get information on the ground. There are delays in relaying this. They're not as sophisticated in terms of the public health response in some cases. We have a vulnerability in the sense that these emerging threats don't stay in those localities. How can we as a society work together to stop some of those? Anybody want to take on that?
Boy.
I'd say, biological warfare. We can forget just the spread of
to engage in biological, that's what you want to do?
Well, I'm saying that is the risk that you can see. It's always been available. You had an ethical system that was in place after World War II. We can question whether that system is still in place today. And so one of the keys to this whole area is understanding biologics and what the access or potential antidotes are to them, whether it's Ebola or whether it's an attack that's planned. So those are both of them. But I would say to you right now, the #1 disease being spread through the world is obesity and the side effects on that, Cliff.
That is a tweet right there.
So you have a great opportunity to create data analytics that can collect data on the ground a little faster and be able to deploy faster, more economical solutions than just deploying through not-for-profit and charitable organizations. Today do most of the work.
Thank you very much, Joe, George, Mike. Thank you so much.
Thank you, Cliff.
Thank you.
Thank you.
So, science is under attack in America, including but not limited to the widespread fear of vaccines, which we just talked about, and denial of climate change and evolution. Denialists replace the open-minded skepticism of science with the inflexible certainty of ideological commitment. To discuss how science can overcome the naysayers, we have a fantastic panel of physician scientists. Please welcome to the stage Dr. Susan Desmond-Hellman, Peggy Hamburg, and Lloyd Minor with Dr. David Agus. Thank you.
Thank you all. This, to me, is one of the most important topics today, which is the future and what's going on in science. You know, basic science is the foundation of everything we do in health, medicine, technology, and it gets shortchanged for a lot of reasons we'll talk about. We're privileged today to have 3 people on the panel who literally are 3 of my heroes. Sue Hellman, to my right, Sue Desmond Hellman, used to be president of Genentech. She is a remarkable physician, scientist, leader who's now CEO of the Bill and Melinda Gates Foundation, who we were just talking, we met in the mid-1990s when we were children, and actually worked together on a drug that is now on the market helping women with breast cancer. Peggy Hamburg, who is the new head of the American Association for the Advancement of Science. All those A's kind of screw you up a little bit. And is former commissioner of the FDA and truly a transformative leader in healthcare. And Lloyd Minor, who is the dean of the Stanford University Medical School and has led their precision medicine and really pioneered a program to try to bring precision medicine to the daily practice of medicine. So when we talk about science, most people's eyes glaze over. Science is not something that is brought up. Medicine is brought up, health, other things, but science is not exciting. Why is that? Why isn't it every child wanting to be a scientist today?
Because we make it boring. We start when kids are young, especially girls, talking about science as if it's books and tests and boring. It's one of the things I love most about global health. If you want to get kids or students excited about science, talk to them about children dying and how science can keep kids from dying before they're 1 year old, before they're 1 day old. That changes from something that I'm furrowing my brow, trying to remember, maybe boring, to something like, I want to learn more. I want to hear how I can help other people. I think it's how we talk and how we think about science that furrows everyone's brow.
It's interesting. Peggy, you know, right now we're taught biology, chemistry, physics, each distinct disciplines, but obviously the world has them merged or converged. Can we change education?
Well, we certainly need to change everything about how we work, how we live, how we think about health and disease, and education is a big part of that. Yeah, I think we have to look across and realize that all of the problems before us, big and small, have complexities that require working across boundaries, whether they're disciplinary boundaries or sectoral boundaries or, you know, national boundaries. And I think, you know, the way we teach things, I mean, Sue said, you know, we do a pretty good job making science boring. We also, you know, make it, you know, this hour you do this, that hour you do that, next hour you do this. You don't relate the things. And certainly for me, when I went to medical school, which, by the way, I did not enjoy, I think medical school has gotten a lot better. But, you know, for 2 years, we sat in a classroom, and we were lectured at, and we memorized things. We forgot them, and we memorized them again. But there was no linkage made to what we were studying really had to do with taking care of patients. And for me, that big disconnect, you know, almost, you know, really made me not want to continue in medicine. And for lots of reasons, I went on to do other things anyway. But I think we need to integrate.
Lloyd, you know, obviously, you know, we're taught to, as you alluded to, memorize this bone, this muscle, everything in the body, and anatomy and physiology. It's memorization. In today's world, I could take my iPhone out and look up anything. And as a patient, you probably want me to do that and not rely on my memory to do things.
Or your little index card.
Yeah. It's true. We used to carry around index cards in our pocket, you know, as an intern, and you would look up everything, talk about the patients.
Microscopic writing.
Right. And you write as small as you can, everything on one card. Can we change education to make it about actually knowledge and thinking and empathy?
Absolutely, and you know, you can get those flashcards electronically now. There's some companies that focus on that. I think we have to re-envision medical education. I think we are doing that, and also view medical education as a continuum. It doesn't end with medical school or residency, but continues throughout, you know, the practicing lifespan of a physician and other healthcare professionals. And also, I think all of us in biomedicine need to learn more about how to communicate what we do with the public. Michael Spector, science writer for the New Yorker, has remarked that, you know, we should be giving talks at Rotary clubs and Kiwanis clubs, not in Palo Alto or Cupertino, but in Kansas City and Wichita. And I think there's a lot more we can be doing and need to do about communicating what science has brought to society, to health and society. I do think, though, and Mark Bertolini brought this point up in the discussion that he just had a few minutes ago in this conference, that we also deal with this very vexing problem of the loss of hope among large proportions of young people today. And that's something that just education alone is not going to address. I think it's much more fundamentally at a societal level that we have to relook at how we reinvigorate the social contract with people in the country.
In Hollywood High School, there's a sign above the science lab, and it says, "Science is truth found out." And you know, if you think about it, it's a very profound statement, but is it true?
It is true. One of the things I love most about science is public health. I love public health because it's inclusive, it's powerful, it helps more people than virtually anything else I've experienced as an innovator, as a product developer. And you use statistics and inference, to use a fancy word, in public health. Everything about those statistics, everything about that inference is about predicting what truth really is. And so it is, it's so compelling when you're learning new things to say, eureka, we now know truth. The best scientists are always using the scientific method, which is, this is truth as of right now. Truth can change and evolve. And I think that that's one of the things about science communication that is the most challenging. If Peggy knows this because of Food and Drug Administration. When I worked with Food and Drug Administration and you and I worked on new cancer remedies, it would be, is this drug safe and effective for breast cancer with these kinds of patients? That actually can change. That can change so that you knew a new side effect, or you had less or more confidence in it working, or there was a better drug that was more safe or more efficacious. What everyone in the world would like us to do is to say that truth is forever. It's truth as we best understand it today. And so that's not fraud. That's not wicked. That's science. But the fact that you're predicting truth for the best scientists makes you humble.
But there's so much noise in our space, right? Every day you read, you know, something and it's counter to something else. And that noise just makes people turn off. And in order to get this normative change, you need leadership. And we don't have lots of leadership in our space, right? When the greatest healthcare leader over the last decade is the former mayor of New York City, you know there's a problem with what we all do. And obviously, you know, you saw it, you know, at the FDA, people making claims right and left without data behind it. How do we provide guidance in this sea of noise?
Well, I think there are a couple aspects to this that are important. One is that, as Sue was saying, science is a dynamic process, and you establish an understanding based on the best available evidence at that time. But you do need to always be questioning, and in that process, science changes. And for some people, especially in a world where the media, you know, jumps on, you know, headlines, this is the cure, this is don't eat this, eat that, and then the next week it's, well, maybe that's not quite right. The public starts to be suspicious and distrust science because they feel like, yesterday you told us this and now you're telling us that. So we need to work on the understanding of the scientific process, that people, really understand that it is dynamic, and the notion of hypothesis testing and evidence generation. In addition, you never have all the data that you want to make a decision, and that's always a challenge. But we do need people who are advocates for science. We do need people that can go out to Wichita or go to New York City. We still have work to do there, and explain why science matters and how it's making a difference in people's lives every day, so they can make better choices for health, so they can understand the technology that underlies so much of modern life, et cetera. By the way, I'm having problems even signing on to the app for the schedule for this meeting, so I'm one to talk. But I think there's that fundamental disconnect in terms of people sort of appreciating and understanding the science in their lives, and then why we need science and technology to address the most pressing problems before us in the modern era, whether it's health and disease or poverty or climate change and the environment or the future of our civilization. Science and technology really matters.
So I get it for translational science. I think the public gets it. But do we need basic science?
Absolutely. I think because everything.
That was a leading
really,
question.
That is a softball, but no, I would hope absolutely. Good translational science comes from great fundamental discovery-based science, and some of those impactful advances in medicine have come from discoveries made not with the intent of having impact in medicine, but with the intent of really understanding the way a biological system, with the ultimate evolution being a human, the way a biological system works. And we've never been at a better time to do fundamental discovery-based research than today. The advances in technology, biology in particular, has always made leaps beyond increments with the introduction of new technologies, and those technologies are more abundant today, and their transformation is more impactful today than ever before. And also, biology and medicine today are firmly quantitative disciplines, which they weren't as recently as 15, 20 years ago. So now people from more quantitatively focused disciplines like engineers, computer scientists, chemists are focusing on biological and biomedical problems because they're amenable to the type of science that they've learned and that they know how to do and that they now feel they can do most impactfully in biomedicine. So at our institution at Stanford, for example, over a third of the faculty in engineering, and not just bioengineering, but all the departments in engineering school, over a third are doing research related to biomedicine, not because anyone's told them they have to research biomedical problems, but because that's where their interests have been drawn based upon the impact that they think they can have. So there's never been a better time to do fundamental discovery-based research. And also, though, I fear that the challenges to doing that, both the skepticism about its value and the difficulties in finding funding to pursue that research, have also only increased with time.
Science is very hierarchical. You have to move up the food chain until you can start to really make an impact in most places. And I can graduate Stanford tomorrow and have a startup and be CEO and lead it, but it takes me a decade before I can be a PI on a grant, et cetera. How do we change that? How do we let the young generation have impact sooner?
Well, I think there's a number of different ways. The first way is to recognize that by its very nature, science shouldn't be exclusive. One of the best experiences I've had since being at Gates Foundation was talking to a farmer, Patricia, in Malawi, who showed me how she was growing her maize to avoid aflatoxin and how she stored her crops so that they wouldn't mold. And if you could hear her, she was better than any scientist I know at describing how to keep her food healthy. I mean, we throw around food biosecurity. She knew what she was doing. She was talking like a scientist. That's the ability to have citizen science is vastly underrated. And I would encourage anybody who cares about science to experience things outside of the walls of the United States, literally. You see the best notions of science in people using it and experiencing it every day. Today, the way that we have formal science, getting a PhD, getting a master's degree, I don't think that's going to stick around, because getting your first R01 grant, your first big grant from NIH at 42, I think it is not sustainable. But the ways we try and do it is we have things like Grand Challenges grants. We have grants that encourage people to do science no matter where they come from, high-risk science, where you don't have to prove what you're going to prove before you can get a grant. Inventing new ways for people to access science and access leadership in science, no matter who they are or how old they are. I don't think we're for long the way we're doing it now.
You know, what Sue is referring to is that when you apply for an NIH grant, most of the time you've done half the work and you have the answers when you apply for it. And that makes you more likely to get it. And you can't really take risk. You know, one of the problems that scientists face, I think, is publishing, right? There are a dozen or 2 dozen great journals, and then everything else is kind of an afterthought that doesn't really, make the impact the great journals do. And, once something is published, it's there in the public record forever. Whereas, as you alluded to, science changes. So I can go back 30 years and find anything I want and say, hey, there's a paper that shows it, even though it's been disproven, because it's static. Yet in today's world, where many of you have technologies that make the dynamism happen in every other business, we haven't changed ours. And we still have this system where these journals, and by the way, you have to pay. If I want to see your paper, most of the time I have to pay to be able to see your paper, even though the government funded your research. How do we change it to get young kids and allow citizen science, or allow somebody to put something that happened experience out there so we can all learn from it and move forward instead of backwards?
I do think this is a really complicated question, because you want to have published science reflect good analytics and reliable data, but you do want it to be available. You don't, number one, want it to be restricted for long periods of time when that knowledge could make a difference in people's lives and advancing science overall. And also, you certainly don't want it to be the situation where you have to pay to get access, et cetera. And we want more openness and transparency of sharing of data and learning. We also, I think, importantly, want to also be able to learn from failure. And very few studies that have failed, get published in Science or Nature. Yet that is some of the most important science at the end of the day, because not only does it give you insights into the underlying scientific processes, but it also prevents other people from spending a lot of time repeating failure rather than learning from failure and advancing knowledge and understanding. So I think these issues about publication are really, really important. I don't think they're completely straightforward. Then you can bring in the question of tenure and how does publication sort of shape the kinds of science that are done, and in the process, are we omitting important areas of science because they aren't sort of sexy or tenurable kinds of research? And I think that is a big gap. And from my perspective, really, really critical aspects of science aren't being adequately funded, aren't being adequately rewarded, and as a result are underdeveloped in terms of the opportunity.
Well, thank you. I want to open it to questions to the audience. Dr. Barker.
So, thank you. That was that's you're in my wheelhouse. One thing that's happened, I think, over the last several years in science is we've all become so specialized. I can tell you that the biologists in any given room, the biologists that actually know very much or remember very much about their physics or their computation, are very, very few. And today, we're moving toward a totally computational-oriented world, and we don't have people trained. I can tell you something like the Cancer Genome Atlas, we had maybe 30 people that could actually analyze that data. It's very much like what we've done in medicine. You go, God help you, you've got a heart attack, you have a GI problem, well, you're gonna have to go to 6 other people. So how do we get out of this specialization of science and back to convergence of science in a way that really educates our young people? Because we're not educating them, we're making specialists of them. And I think it's a problem. And I can tell you, I work a lot with the Chinese. They don't do that. They're actually trying to, and I come from a university, by the way. We have no departments. We're organized around societal problems, as Sue knows, I think.
Dr.
So
Meyer,
how do we fix this?
what do you think?
Expert.
Sure. I agree with you. I think we need more physicians who are data scientists, and we need to, and I think we and others are looking carefully at our medical school curriculum. You know, we have at Stanford medical students in their first and second years, because we follow the calendar of the rest of the university, who are taking, you know, courses in computer science and statistics. So they're not just restricted to medical school courses, and also providing the opportunities even after medical school to have further training experiences that get people fluent, literate, and able to interact with constructively with people who are experts in data science, and in the types of approaches that you so well described are needed in order to really mine the data that exists today and translate that data into actionable information. And that's a big gap right now. The gap, there are 2 gaps in being able to leverage the power of the data today. One is getting the data in, particularly for data that's trapped in electronic health record systems, which tend to still be siloed. And the other is the analytics needed to really glean information from those vast amounts of data.
Another question.
Hi, Laurie Glimsher from Dana-Farber and Harvard. So David, I was horrified by your question. Do we still need basic science? Do you know how cisplatin was discovered? It was discovered by Barney Rosenberg, who was a bacteriologist who wasn't even thinking about cancer, because he was looking at why bacteria lose their shape or turn into different shapes. And he figured out that it was something in the fluid after he gave them an electromagnetic field. He purified the substance, it was cisplatin. And then he teamed up with biologists and with clinical trialists, and that's how cisplatin occurred. So, you know, without basic science, there's nothing to translate.
So I love that, and I'm going to pile on because I so agree with Lori. One of the most promising mosquito zappers we have right now is something called Wolbachia. And the details aren't important, but Wolbachia were discovered through someone studying the microbiome of insects. Now, if you think that's not basic, the microbiome of insects can now be exploited to help people fight off dengue, Zika, a lot of diseases you don't want to get. So the world needs basic science more than ever.
But this is really a critical moment to try to explain that to the public and policymakers, because there really is an eagerness to discount the importance of fundamental science, to question the investment of the federal government in fundamental science. And if the federal government doesn't fund it, I don't know who's going to.
And I would just add that I think we're all very fortunate to now have a generation, particularly of young philanthropists, who increasingly are seeing the importance of fundamental discovery-based research and who are providing transformative support for that research. But that alone won't do it.
No, listen, I thank you all for this panel, and I am obviously an enormous believer in the power of basic science. What I think we fall short on, and I think all of us are guilty, is we have to talk more about it. And we have to get that message out there, and we have to tell the stories about it. When you tell a story about, well, this basic science serendipity's led to X, Y, and Z, it's hard to convince them to put their resources behind serendipity. But I do think we have to start to keep telling the stories. Basic science changed the world from Edward Jenner on up, And I think that we have to be the message to make it continue. And we have to change education. We have to have professional societies that actually make it encouraging for young people to go into it. And obviously, we have foundations that at the same time are allowing it to change the world, not just locally, but globally. I thank the panelists, and I thank you all for listening. I'm supposed to have you guys leave the stage. I'm not good at stage direction. And I walk over here. The power of Fortune Brainstorm Health is that we can now go in the hallways and continue the conversations. And so I apologize for cutting the question short, but we have a very strict taskmaster who's telling us what to do. We now have a break until 4:25, and then we are back here with some very exciting discussions. And I think the rest of the afternoon and the evening will be somewhat illuminating. Thank you very much.
most powerful women, Michal Levram.
It is great to be here, and we wanted to remind you to tweet #BrainstormHealth throughout the afternoon, evening, and night if you want, and during tomorrow's sessions, of course. So for the past decade, our next guest company has engineered, programmed, hacked, and crowdsourced issues of inability and inaccessibility and provided low-cost solutions for the most vulnerable on our planet. Here to share some of these successes, please welcome the founder and CEO of Not Impossible Labs, Mick Ebeling.
Hey there, how is everyone doing? Good. All right, so I'm up here today because of this guy. Go back once, if you could go back on that slide for a second. For this guy. So I met this guy because it was date night. And my wife and I were planning on going out. A friend of ours came by and hijacked our plans, ended up taking to this gallery event. And at the gallery event, we were blown away by this thing. And I asked my buddy, I'm like, hey, I'd love to meet the artist. And he said, you can't meet the artist. The artist has ALS, Lou Gehrig's disease, and this is a fundraiser to raise money for his care. And so I said, oh, it was amazing. And I met his family and met his friends and brother and father. And then we went home. And then we became more infatuated with what this guy's story was about. And getting to know them, realized that he lived 13 miles away from me, and he was lying motionless in a bed. And the only way he could communicate was through, you go back one slide, we keep missing that. The only way he was able to communicate was through a piece of paper, a letterboard with the alphabet on it. And so people would run their finger along it, and the finger would get to a letter, and he would blink. So 7 years in a bed without able to communicate, and this is how he was communicating. To me, that was absurd. I don't know anything about medicine. I don't know anything about ocular recognition or total paralysis, but to me, that didn't seem right, that in a city with a GNP greater than most developing nations, that's how someone was communicating. So I brought together a big group of people, and we hacked and programmed and came up with this solution that we basically did because we saw it was absurd, and said we just have to solve it. So we did something that we call commit and then figure it out, which is you don't have to have the experience or the credentials. You just have to say, that's wrong, we got to change it. So all these people started to hack and program, and we came up after a bunch of work with a device called the iWriter. It's cheap sunglasses, a coat hanger, duct tape, zip ties, a web camera, and it looks like this. And we took it to his hospital room, we gave it to him, and downstairs in the parking lot, we set up a big projector from the room, a signal down to the projector. We projected on the side of a building, and for the first time in 7 years, Tony Temp Kwan, that paralyzed artist, drew again. And it was awesome. And then we went out to celebrate and had some beers and went home. And then we woke up the next day, and it was Time Magazine's Top 50 Inventions. It got all this crazy press. It's now part of the permanent collection at the MoMA. And that was, for us, that was the launch. We didn't know it, but it was the launch of this whole concept of using technology to do good, technology to solve problems of inaccessibility. And that's what I have. That's the company that I launched called Not Impossible Labs. And so Not Impossible Labs is really about looking at things that you, as a human being, you consider to be absurd, that have to change. And you say, that must change. We must change that. That doesn't seem right. And then using that as a way to create what we call technology for the sake of humanity. Part of our secret sauce is to use story. As a filmmaker and as someone who lives in Hollywood and Venice Beach, we use story as that way to actually take the solutions that we make and make it accessible. That's how we scale. We scale through story. And that lens that we look through in the storytelling that we do is this lens of help one, help many. And what that means for us is we don't have the means to solve this for everybody, right? The Bill and Melinda Gates Foundation person was up here a little bit ago. They have those means. We don't. So we solve for one person, but solving for one person and then telling that story powerfully, that's how we scale. So the question we start every time, every absurdity we attack is asking ourselves the question, who is the one? Who is that one person if we solve for one, that can lead to solving it for many? So the second part of the story of Not Impossible happened because I got introduced to this incredible doctor named Dr. Tom Catena. He's this incredible doctor based in the Nuba Mountains, which is between Sudan and South Sudan. He's the only doctor within a 1,500-mile radius. He has to, anything medical, he has to actually do it. Learning about this guy, I found that one of the things he hates to do is to perform amputations. It's a war-torn area that's constantly being bombed by President Bashir. Part of the stories he talked about in his disdain for having to perform amputations was about one particular young boy who was out tending his family's goats and cows, heard the bombs come, they come every day. It's like the sun coming up. Didn't have any place to go to, so he went and he hid behind a tree, wrapped his arms around a tree. The tree protected his body from the blast, but because his arms were on the other side, it blew off his arms. And the story, this image in the story that I read about this boy is what led to this. Recognition of the absurdity and saying, we got to change this. We committed, we figured it out, and then this happened.
Be done, be done. Daniel is just one of 50,000 amputees left in the wake of the bloodiest war Africa has ever known. We flew into an active war zone in Sudan with 3D printers, laptops, spools of plastic, and the goal to build Daniel an arm.
You ready?
The concept of Project Daniel was hatched on July 11th. And on
So thank you. That's Project Daniel. You can go to our site and see more stuff about Project Daniel. So we're working on a bunch of other things right now. After Project Daniel, I got exposed to this device, which is called a gait trainer. I was told that if kids with cerebral palsy use this device consistently and consecutively for about a year, a child with cerebral palsy might walk again without a crutch or an aid. Problem was they're too expensive. So a kid could age out of never having a chance to use this. And it wasn't just in developing countries, this was in our own country. And I said, that's absurd, that you can't have a tool that can actually help kids walk and then not have the ability to have those kids get on it. So we brought together a team, we started to hack, and we're coming up now with something that is better, it is faster, it is stronger, and it's made of car parts. So this thing doesn't break down. If it does, you just give it an oil and lube job, it'll run for another 5 years. And if you need a part, you go to the auto parts store. You don't have to sequester some part from some big medical company. The absurdity of hunger. 48 million Americans go in a food insecure environment. 1 in 3 people are homeless, are veterans. 1 in 5 kids live in a food insecure environment. Everyone's seen this statistic that hunger is not caused by a lack of food, but the lack of access to food. So we said, okay, enough of hearing that, let's do something about it. So we created a text-based application that allows NGOs to text their constituents an ability to go into a place, colliding supply and demand, and go into a place and pick up a meal without being identified as homeless or hungry or poor. They can just walk into a restaurant and claim a food in a dignified way, the way anybody else does. We piloted this in St. Louis, and we fed over 11,000 meals via text message in 90 days. This is something we're deploying around the world right now. This last one, part of it, I don't know if anybody's from here, but commuting in Los Angeles is a big deal. This is how I commute to work every day. So getting into work, I skateboard. Part of being exposed to the skateboarding community is people fall. A friend of mine fell, hit his head, hit the back of his head, lost his sense of smell. Made me think, wait a second. If you hit your head and lose your sense of smell, that means you don't smell with your nose or see with your eyes, taste with your tongue, or hear with your ears. You do that all with your brain. So maybe there's a way that we can hack around the ears, the broken part, and make it so that the deaf can actually experience music again. So we've hacked together a way now that allows the deaf with wristbands, ankle bands, and a vibrating vest to have music signals sent to the body. That vibrates the music signal, so now they can experience music. We took it out, the deaf lost their minds. They're like, this is amazing. In fact, we're not going to give this back to you. They threatened us. We ran out of deaf people to try it out on, so we took it out to people who could hear. They said, this is the future of music. This is how music's going to be experienced. And we said, that's incredible. Then a friend of ours said, hey, send us some of those. We actually want to try it out on people with tremors. And we did. Tried it out with someone with dyskinesia. So we said we think we're onto something here. So you know why we pull all this off? Because we shouldn't. That's why we pull it off. We're not the ones. We don't have to look in your programs. There's no initials behind my name, right? We pull this off because we have no credentials, no training, no tangible reason to succeed. And I write about this. The reason we pull this off is that we recognize something that's absurd from a human standpoint. From a human standpoint, we say that shouldn't be that way. That's not right. Then we find our one, we commit and say Geronimo, and that's how we do it. So I'll leave you with this. It's one of my favorite quotes in the world by Horace Mann. He says, refuse to die until you have won some victory for humanity. If you've done something good for the world, you can go. If you haven't, you got to stick around for a little bit longer. So the question I ask you guys today is this. What's your victory going to be? What's your victory going to be? Or what's that thing in your work, your school, wherever you are, what's that absurdity that you're going to find that you can solve from a human standpoint that you say, no more, that can't be that way. Let's go fix it. Thank you, guys.
Thank you, Mick. Okay, from that, the next logical topic is clearly agriculture, right? Agriculture has been slow to embrace new technology, but now, with more and more technology being out there and more accessible than ever, it's time for agriculture to go high-tech, or even more high-tech, I should say. There are now hundreds of companies offering everything from farm management, precision tools, to bots, and drones into the space. Here to share how big data can revolutionize our food production, please welcome the president of Sensei, Daniel Grunberg.
Hello, everybody. My name is Daniel Grunberg. And a few years ago, a number of things happened to me at once. I hit a milestone birthday. Then later that week, I stepped on the scale and saw that I was the highest weight I'd ever been by a large margin. Thank you. And that same week, I got a call that my father was being rushed to the emergency room to get a quadruple bypass surgery. Now, thankfully, my father recovered, but it was definitely one of those moments where you stop and you reflect and you think about your lifestyle decisions, because apparently all the good habits I had went by the wayside being an entrepreneur. So I took next year and I started tracking everything I did. What I was eating, when I was eating, what my heart rate was doing throughout the day. I tracked everything I could with the tools that I had. Now, it was all relatively low tech, but the process helped me generate an appreciation for using data to make smarter decisions around my personal well-being. So fast forward to today, aside being 40 pounds lighter, I am now part of a company that shares this belief. I'm the president of Sensei, which is a new company founded by actually one of the chairs of this event, Dr. David Agus and Larry Ellison. We are guiding you towards greater well-being. So we're creating an ecosystem of products and experiences that are all designed around one intention, which is to empower you to grow well, as we like to say, so living longer, healthier lives. And the first place we're starting is with one of the largest contributors to your overall health, food, by building more modern farms. So before we talk about that, let's step back a second and think about the fact that human beings evolved over hundreds of thousands of years to eat the food that nature made. Then we changed the food that nature made. Ever since Gregor Mendel genetically modified a pea in 1856, food really hasn't been the same. We've had generations of farming optimized for yield and drought resistance and pest resistance, but the original nutrition and taste profile went by the wayside. Now, with a growing population trending towards 10 billion people by 2050, the quantity of food available is absolutely really important. It's just not the full picture about what's going on in agriculture today. So McKinsey put out this study recently, and they said that agriculture is the least digitized industry of all industries. But that's rapidly changing. Last year, there was about $3 billion invested in new technology. So now ag tech has been born and is top of mind because it's enabling us to scale farming more sustainably. So with that said, what's Sensei up to? Well, we are building a global network of hydroponic farms. For those of you who aren't as familiar, a hydroponic farm is one where you grow fruits and vegetables directly in water beds with nutrients in a climate-controlled environment, so this can be a greenhouse or a building, and you have sensors and software that climate-control the environment to create the ideal conditions for plants to thrive. Now, our first farm is on the island of Lanai, which is in Hawaii. Now, this is a state that imports 85% of its food, and where on average it takes about 10 days for food to get to the islands, so it's degrading that entire time. As part of our mission, we are looking to make our operation fully sustainable. So we use about 1/10 of the water as compared to conventional farming. We use no harmful chemicals, and I'm happy to say that we are partnered with Tesla to provide solar energy at our facilities. But there's a bit more to our farm. So the conversation in hydroponics today has mostly been around nutrition per acre, or yield per acre. So how much yield can we get per square foot? Sensei's focus is different. We focus on nutrition per acre. So to properly nourish the world, we're collecting and analyzing data on all the fruits and vegetables that grow in our facilities, then creating a continuous feedback loop to then help us better understand how to make food closer to the way that nature intended it. And so from black trifoli tomatoes, something that will grow all the way to Kamatsuna mustard greens, we'll reproduce the best of the best, and then we'll tell you the exact nutritional breakdown at the time of harvest, because we believe that you deserve to know what you're eating. With that said, our door is wide open to collaborate. We're just getting started, and thank you so much.
Thank you, Daniel. Okay, moving on along from augmented reality, 3D training tools, and human head transplants. Is this a thing? You guys, raise your hand. Have you heard of this, or have you done it? No? Okay. To advanced immunotherapies used to treat cancer. Innovations in the medical field are coming at us fast and furious. But which ones are the game changers that will have the biggest impact on the future of healthcare? I'm going to go with human head transplants. Let's hear from 3 experts immersed in the intersection of innovation and creativity. Please welcome James Park, Dr. Martine Rothblatt, with GE's Sue Siegel.
So good afternoon. I have to say, when I was told whether I could moderate this panel, and it was going to be called The Mother in Invention, I said, how do you turn that down? And then they told me who was going to be on the panel. And for those of you who aren't familiar with who our panelists are, Dr. Martine Rothblatt, to my right, well, both of them are to my right. Dr. Martine Rothblatt is CEO of United Therapeutics and has had an illustrious career that has ranged from being studied law, and also then went and co-founded GeoStar, and then went on in the satellite space to actually start Sirius Radio, satellite radio, which has now become Sirius XM, and really changed the way we participate with radio. And if that isn't enough, something that you probably hadn't Googled about her, and she does many other things, but something you hadn't Googled about her is she's actually a jazz pianist and flautist. So something quite distinguishing in terms of some of the things she does. James Park is the co-founder of Fitbit. He's also the CEO. And James, very similar to Martine, also co-founded 2 other companies, both of them not in the health space. So when you think about that, it's really taking a whole bunch of different industries and then bringing them into the healthcare space, which is quite remarkable. Now, when you start to really think about the possibilities of these merging industries and being able to take advantage of what has happened in other industries and bring them into healthcare to really start approaching this notion of consumerism and decreasing cost and access, is something that you start to think what could possibly help in terms of innovation and also in invention. So with that, I'm going to start with some questions here. And I'll start with a question for both of you. And both of you started out of the healthcare space. So tell me a little bit about what brought you into healthcare and why bring the experiences that you have into the healthcare space. And I'll start with you, James.
Yeah, so I think the best way I can answer that is actually with the founding of Fitbit. It was late 2006, and I still had lots of time to play video games back then. So Nintendo had just announced the Wii, and I was super excited. Waited at Best Buy at 6 a.m. in San Francisco for like 3 or 4 hours. And I took it home, and that was really the first use of accelerometers or motion sensors in a consumer setting. You know, been using airbags and laptop hard drives, et cetera, but for the first time really exposed to consumers. And the way that Nintendo had melded sensors and really amazing software and made gaming and exercise together into something that was really active and fun and positive. That was what inspired me to start Fitbit with my co-founder. And you know, what we thought was, how do we capture this magic and put it into a form that it could be with people 24/7, not just in the living room. And back then, it was primarily a consumer focus. We're thinking about how do we get the average American just up and moving more, healthier. And we hadn't really thought about what that meant for healthcare. I mean, we were just focused on surviving day to day. But I think that origin of really being focused on the consumer experience, how to motivate people, how to engage people, is now turning into something that's a critical asset when you think about healthcare and how to manage chronic conditions where behavior change and the psychological aspects behind it of motivation engagement are incredibly critical to being successful. So I feel really fortunate in having started out this way.
So your transition really was all around knowing the consumer and potentially being able to engage in the consumer in a health perspective. Had you known what you were going to get into with all the regulatory elements in healthcare, we're going to come back to that in a second. So Martine, what brought you into healthcare? Your story is quite unique, and would love to hear a little bit about it.
Thanks, Sue, for the question. My youngest daughter was diagnosed with a rare and generally fatal condition called pulmonary arterial hypertension. She was just a little kid, younger than 10. She ended up at Children's National Medical Center in Washington, D.C. The doctor said her condition was fatal, would be so within less than 5 years. There were no medicines approved for the condition. Nobody was interested in working on the condition because only 3,000 people in the whole US had it. He told me there would be no pharmaceutical company interested in it. And the best we could do was just enjoy the last 2 or 3 years. After first trying to verify what he said, talking to other experts, talking to the handful of leading doctors in the field, it became clear if I didn't do something personally to change the reality, it wouldn't be changed. So I just took it upon myself to spend like round the clock researching the indication, the illness, the disease, the molecules that might be at play in the disease, researching everything that had been tested by pharmaceutical companies, and finally finding a molecule that held promise for arresting the progression of the disease. And today, that molecule is the foundation of our company, United Therapeutics. And there are thousands and thousands of people using our medicines. And instead of there being just 3,000 people with the disease, there are now over 40,000 people living with the disease in the US because they're not dying. And best of all, our daughter Genesis is now 30 years old and works in United Therapeutics, helping everybody else develop even better treatments.
Now, if that isn't inspiring enough, Martine also, to actually synthesize this molecule, she had to find a chemist who would be willing, because it had 24 steps, I believe it is,
yes.
And 2 of those steps caused explosions.
Yes.
She actually had to find someone who was willing to do this, and she did, if she'd pay them $100,000. And here we are. So an incredible story, to say the least.
Yes, that's Dr. Moriarty, the former chairman of chemistry at the University of Illinois, Chicago.
Now, Martine, you've also done a tremendous amount in a number of different areas. And you know, it was billed here, and we didn't really talk about this before coming out here, but it was billed here about this notion of head transplants. Well, they're not really head transplants, but you are doing things with regards to transplantation or the creation of organ and regeneration. And you're also doing something around the digital twin, if you'd like, where you're trying to capture consciousness. Talk about that a little bit.
Okay, so thanks again. Very obviously mega question, but briefly, our company, United Therapeutics, is working to increase the supply of transplantable organs. Specifically, we focus mostly on the lungs. And today, there are about 2,000 lungs transplanted a year, but over 250,000 people a year die of end-stage pulmonary disease or lung failure. So clearly, the transplants that are occurring from human donors are satisfying just a very small percentage of the need. So we've developed a suite of technologies that allows us to increase the supply of transplantable lungs. The techniques also apply to kidneys, hearts, and livers. And in this way, I believe we are making some really big strides in increasing the supply of transplantable organs. So that's a lot of the future work for United Therapeutics, and that's part of our longer-term business plan. Completely separate from that, having nothing to do with United Therapeutics, I have a personal technology foundation that I funded, and this foundation is active in the area of getting people interested in coding for replication of personality and what might be called a consciousness operating system. So we call that mindware. And there are now many thousands of people throughout the world, most of whom have nothing to do with our foundation, that have been inspired by things like our Bina 48 robot, which is a kind of a Kitty Hawk level example of cyber consciousness, to say, hey, maybe for patients with end-stage illnesses, maybe we could capture a lot of their consciousness. Worst case, it means that their grandchildren, great-grandchildren can interact with them. And best case, we may be able to ultimately provide them kind of a ongoing consciousness and ability to participate in reality.
Thank you for sharing that. So if that's not invention, I mean, someone else define it for me, please. So James, I'm going to turn to you. And I said I'd come back to this notion of chronic disease and healthcare, and really starting to think about how you take the technologies that you brought to bear, Fitbit, and now bringing it to the next step, which is not just about health and wellness, but truly in the space of managing disease. Can you tell us a little bit about that?
Yeah, there's a couple of things that we've been doing. So overall, as a strategy for the company, we've been trying to deepen our reach within healthcare, working with employers, payers, health plans, researchers, et cetera. Two of the most interesting things that we've been doing, we just acquired a company called Twine Health, which is a really efficient digital platform for human coaching, because what we've realized after years of doing this is that you can't just really give technology or even motivational software to people. Solutions to manage conditions like diabetes, hypertension, sleep disorders, et cetera, really become effective, optimally effective when there's a human element to it. So really excited to have Twine integrated into some of the solutions that we're offering our partners to manage some of these conditions. And then, where we're also looking really optimistically towards is this idea of digital therapeutics. So recently, we announced a partnership with Dexcom and United Healthcare, which is the nation's largest health plan, to look at the Medicare Advantage population and see if we can effectively prescribe exercise as an alternate, as a digital therapeutic for diabetes medication. So the way it would work is someone would wear a Dexcom continuous glucose monitor. When we detect that there's a high spike of blood sugar, we can effectively and algorithmically prescribe exercise at a certain time, interval, intensity, et cetera. And using machine learning, we can actually give them the right dose of exercise and watch their blood sugar drop. And they can cut their use of medication pretty dramatically. So this is a pilot that we just started. And if this can pan out, it can result in massive savings to the healthcare system. So a couple of the more interesting things that we've been working on.
That's great. And what should we expect to see with your Twine integration? How soon will we expect to see some of the solutions?
Pretty immediately. Twine's been already working with workplace health providers, which are on-site clinics, et cetera, who provide healthcare services to extremely large employers. We're continuing to sell through those channels, but we're immediately selling to large health plans and our existing employer base, which includes about 1,400 employers, 70 of the Fortune 500. So immediately in 2018, there's a lot of people who are going to see the benefits of this merger between human coaching and data-driven wearables and analytics.
So I'm going to ask one more question, then open up to the audience, and then we're going to close it up. And so data everywhere. I mean, we know that, right? And both of you coming from different industries understand the power of data, and especially in the industries that you've been. As you think about the whole notion of data and you see this push that's happening, it's not so much about the data per se, but it's the different business models that you can actually use around them, create value around them. Tell us a little bit about how you've thought about that in your respective businesses.
Yeah, so for us, we clearly don't want to monetize data directly, meaning sell it to third parties, et cetera. It's not in our interests, and there's already a lot of regulation, including GDPR in Europe, that's going to heavily regulate this for the protection of consumers. But we do see the opportunity in data as managing data flows between different entities is one area. And then secondly, providing insights or diagnoses, some value add on top of the data. So for instance, a couple of the algorithms that we're working on with the through the FDA's new pre-cert program is algorithms to diagnose sleep apnea or AFib. So those are some ways that we could monetize the data by providing algorithms on top of it.
That's great. And it's a subscription model, or is it a?
It could be subscription, or it could be some type of risk-sharing model as well with payers.
And that is to the payers, right? Okay. Martine.
One of the more interesting things we're doing now is all of the patients that are in our clinical trials. We have about half dozen phase 3 and a similar number of phase 2 trials going on. Starting last year, we began genomically sequencing all of the patients that enter into all of our clinical trials. We're in a partnership with Human Longevity, Inc., Craig Venter's company that does this. And we're beginning to unblind the first of those studies toward the end of this year. We're really interested in correlating the results of the patient's outcomes, anonymized, with their genomic sequence data to see if we can associate particular polymorphisms with either especially good responses to our medications or especially high levels of side effects. Our hope is that we'll be able to submit this information to the FDA. They will end up putting it on the prescription label, and we'll be able to lead the way where physicians have your genome on their desktop, and they have access to cloud resources that could tell them, based on your particular genome, certain medicines are especially recommended or not recommended. And we can cut down tremendously, one, on the costs that involve you trying sequentially multiple medicines. We can cut down tremendously on the waste of a person's life who has a chronic, perhaps life-threatening disease, for them to try a medicine just because it was approved on average statistics over a very large number of people. Instead, we can more precisely target the particular medicine to the person's unique genomic configuration. And I believe like the data of genomic sequencing applied to pharmaceuticals, what we call pharmacogenomics, will be one of the most beneficent applications of big data in healthcare.
Great, thank you. I'm going to turn to the audience now for any audience questions.
Hi, my name is Pamela Collins from the University of Washington Global Mental Health Program. My question's for James. You mentioned actually bringing together the human element with a digital intervention, and this is something in the mental health area that we've been thinking about trying to figure out, taking advantage of the wonderful opportunities in mHealth, digital health, and so on. But tell me a little bit about how you're titrating that. What's the right combination of the human versus the digital?
Yeah, I think because people, very qualified people are expensive, I do think we want to use technology to the utmost to make that process more cost effective. So the way, for instance, Twine, we see things as using data and machine learning and providing exception-based management that people can then look at. So actually Twine provides a dashboard to care teams where you might have a population of 1,000 or 10,000 people for whom you're trying to manage diabetes or hypertension. And based on the data that's coming in from wearable devices or other data sources like medical health records, people might end up getting classified as green, yellow, or red. 90% of people are going to be green, 8% of people are going to be yellow, 2% are going to be red. And the human care team can focus first on the people who are red, then yellow, then green. And we feel that that method can be applied in a lot of different conditions.
Okay, so I am told we are out of time. I'm going to do one quick question. Moonshot, you have 2 seconds to answer this. What is your favorite moonshot right now in healthcare?
Anything that could help provide 90th percentile human-based medical care to 100% of people through AI.
Got it. Martine?
Bioelectronics. The nervous system touches every cell in the body, and actually GE and United Therapeutics are partners in supporting the Feinstein Institute on Biomedical Research. We are now trying to hack the nervous system so that we can manage and improve a lot of chronic conditions based on tapping into the vagal nerve and the entire nervous system.
Love it. All right, with that, please, round of applause. Thank you.
All right, thank you all. For those living with legal blindness, vision loss can be harrowing, and it is also very complex to treat. Our next guest company has spent the last decade creating the most advanced electronic glasses available that allow visually impaired people to see the world as it is meant to be seen by addressing vision loss through wearable technology. To demonstrate, please welcome Director of Outreach and Communications for eSight, Jeffrey Fenton.
Thank you so much. It is an absolute honor to be here today. I'm here to tell you about a technological breakthrough called eSight. And before I tell you about it, I want to start by showing a photo. Simple but beautiful photo of a mother embracing her daughter. But it might stun you to know that this is what the photo might look like to someone who's legally blind or living with vision loss. Just think for a second about your day-to-day. Think about a moment and what it might look like if you were living with vision loss. This is a workplace. These are cubicles, things that a lot of us in this room have to look at every single day. This reality that is legal blindness challenged us to ask a really bold question. What if we could use technology to help the legally blind see? And it's a question worth answering, not just because blindness impacts 250 million people on this planet, but because it's a harrowing disease. 70% are unemployed, half are suffering from depression. They tell us that they work 4 times as hard to get 1/4 as far. So this question inspired us to create eSight. And eSight is a magical breakthrough, and it allows people living with blindness to actually see and be mobile and do things that they once would have only dreamed about. To work to their fullest potential. And for the folks in the room here who are looking for good talent, eSight can allow you to tap into such incredible creativity and energy from these folks that once they wouldn't have been able to necessarily contribute. To learn in the classroom, see the faces of their peers, to travel the world independently, which a lot of our eSighters now do, and to participate in the little things of everyday life. This is one of my favorite moments. It's a mother seeing her newborn baby for the first time after living her entire life being legally blind. This is a technology that was created to enable the limitless potential of humanity. And I could spend hours on this stage talking to you about the incredible moments that this technology has enabled, but instead, I want to do something a bit different. I want to show you this technology, and specifically, I want to introduce you to a young man named Joel. Joel's been legally blind since birth, and he now uses eSight to see. And when I call Joel up on stage here, I'm actually going to enable a setting that's going to allow you to see exactly what Joel is seeing. So ladies and gentlemen, could you please put your hands together for an amazing and inspiring young man named Joel Gomez. Joel.
Thank you. My name is Joel Gomez, and I'm legally blind. After hearing Jeff speak, you might be wondering what it's like to wear eSight after living with vision loss. The short answer, it's incredible. With eSight, I can see all of your faces. I can see the faces of my loved ones. I can even see the board at school. I play 4 instruments. When learning new music, I need to see the notes. With eSight, I can do that. My first original song is about my experience and the courage that it takes to be a visually impaired competitive runner. But before I perform, I'd ask you to remember this. Blindness does not discriminate. Anyone, anywhere in the world, could lose their vision. If you or someone you know is living with vision loss, please let them know about eSight. It could change their life. It's definitely changed mine. This song is called Runnin' Blind. Did you know that all our hearts are exactly the same color? We see more when our eyes are covered. No one knows what works anymore. So why not do what you love? No one can see what's behind you when you run. So why not run through the shadows? Run through your fears, run to your heart. Run on faith that you can't hide. 'Cause it's okay to be running blind. Running blind. It's time to chase down lightning. It's time to make your pain your gift. Impossible is just an opinion, and every dream starts with a wish. So why not run through the shadows? Run through your fears, run to your heart. Run on faith that you can't hide. 'Cause it's okay to be running blind. Running blind. We see more when our eyes are covered. Thank you.
Great job, buddy. Great job. Thank you so much. You can head off now.
Wow. Wow, wow, wow. So Jeffrey and Joel, that was amazing. Thank you for that inspirational and beautiful presentation. We're going to switch gears, and we're going to the field of precision medicine. Precision medicine is a term, a buzzword that's been used all over. But I think you'll see from these next 3 panelists that precision medicine is happening. And each of them will show you a different perspective. We have Kathy Giusti, who is the founder of the Multiple Myeloma Research Foundation, and she's also holds the Bob Kraft Precision Medicine Chair and Accelerator at Harvard University, which she runs. We have Athman Laraki, who's the co-founder and CEO of Color Genomics, and Vijay Pandey, who's the general partner in the biofield, and Andreessen Horowitz. And each of them are going to build or bring a different perspective. So we're excited to talk to them now on stage. All right, so precision medicine has been this buzzword for a long time, and we've been talking about it over and over again. Is it real, Kathy? Are we doing it?
Yeah, I definitely think we're doing it. I think because we can now sequence the genome, because we can now share data in the cloud, because patients are starting to understand it, I think we're making unbelievable progress. I do think that some cancers are making much more progress than others. And I think there's still a lot to do, but I think, I think it's incredibly, incredibly hopeful.
Should every patient have their genome sequenced?
I believe so. And I think that what will happen over time is the more you know about your genome, your subtype, that, everything changes so quickly that at least you know that, and you know how your tumor changes over time, so that longitudinal information is helpful as well. So if you know that and then new drugs are developed, then at least you've got a chance at getting them. But I will tell you, we did a survey across 5 different cancers, and the awareness of precision medicine, when we said, do you know what it is, was in the low 40s. So I think there's an element of coaching and training patients on, why do you want to get to an academic center? Why do you want to get genomic testing done? What do you need to know about it? What do you need to know about your subtype? Because it can all be a little overwhelming right when you're diagnosed.
Oh, I get it. I mean, the notion of actually seeing what drives the cancer and being able to target it is very powerful. Color genomics has obviously a very different focus than patients with cancer. And they've got this lofty goal of potentially prevent cancer. When Angelina Jolie said, I have this mutant gene for breast cancer, BRCA, it was $5,600 for a woman to have the right to look at her own DNA. She had to pay a ransom to look at her own DNA. And you guys democratized it, liberated the ability to look at your own DNA. And to that, I applaud you. Why isn't every person in the country being sequenced for BRCA?
Yeah, it's a great question. I mean, I think it's a progressive thing. I mean, to your point, I think earlier there was a huge cost barrier that dominated the rationale behind how you think about using genetics. So in a world where testing costs, $5,000 or more, you just realistically cannot make it available to everyone. And I think that wired everyone to think about genetics as this very expensive, high kind of cost, both financially but also, from a process standpoint, thing to do as part of healthcare. And I think the thing that's been interesting the last few years, when color launched at $250, it allowed us to start walking down the path of, changing the entire rationale of how we think about the use of genetic information, and going from this thing that's, used at the end of the chain only after a family's had a lot of disease in their family to try to explain why bad things happened, to now start thinking about this information as something you do at the very beginning, right? Like it costs potentially less than a mammogram, right? And so, I think now we're at the point where it's literally ROI positive to sequence the entire population. So I think we're now in that major transition phase where kind of the medicine as well as the kind of cost structure have caught up. And I think the big step that's still remaining is a convenience standpoint. It's still, I think, quite inconvenient for people. And that's one of the big barriers that Color's also been working on, is how do you just make it really simple and integrate it into normal practice.
So this predatory practice that basically happened before you came along, and also I should say what happened in the middle was that the patents, you can no longer patent a gene in our country, and that certainly helped a little bit. But this predatory practice, this monopolistic concept of I can charge whatever I want, we see it in cancer drug pricing, we see it potentially in cancer genomics. I mean, there's no reason per se that it needs to cost thousands of dollars. It could cost hundreds of dollars. How can you do it but others couldn't?
I mean, I think in general, I think one of the general issues in healthcare, or one of the challenges, is that they're almost monopoly pricing or monopoly power through the entire chain, right? Going from payers all the way to pharma and to diagnostics, et cetera, where, the value that's being delivered and the, market power does not propagate from consumer all the way down the chain. And I think one of the things that, for us that was a kind of competitive advantage is, we came in with a very heavy tech background. So a lot of the people in the company had very deep machine learning backgrounds. We're kind of from more kind of the tech side. And we were fortunate to, pair with people like Mary Claire King on the genomics side. But we weren't beholden to the the system, if you will. We were able to kind of start almost with a blank slate and use the technology that was there almost from first principles, as opposed to try to work from an existing model backwards.
So for those of you who don't know, Mary King is like the godmother of genomics and helped discover all these breast cancer genes. So she is the hero in the field. So there ain't much better to work with than she is. So Vijay, over the last 20 years, the capital markets have kind of closed down to biotech. And it's not the hot thing anymore. All of a sudden you can start an internet company and be public 3 years later. How did you go into biosciences? And Andreessen Horowitz, one of these big tech investment funds, venture funds, how did they allow you to do bio?
Yeah, actually, it's interesting because things are turning upside down in terms of exits, and that a lot of these tech companies, like storage tech companies like Airbnb, are taking longer to go public, and there's strong reasons for that. I think actually, really the opportunity that we saw was actually not so much in terms of exits, but in terms of how you build companies. You think about Color. Color is a great example of a company built like a tech company, but in the biology space. And we've seen several of them, and I think the future of precision medicine will be incorporating these tech advances, like machine learning, where we're not just talking about, do you have a gene that might might lead to breast cancer, like Angelina Jolie, but for example, looking at your DNA in your body to say, do you have breast cancer right now at early stages, such that she wouldn't have to remove her breast prophylactically. I think these are opportunities that only come when you can combine best founders that have deep expertise in the machine learning side and deep expertise on the bio side, and that's the opportunity.
That's great. The field of business and training young entrepreneurs, business people, we train them to think about best practices, about corporations. Do we train them all on the bio side?
Well, I think we have to teach each other how to do this well. And I think, there's the element of the science, and then there's the element of how you bring business policy to make the science and the technology happen. And I think for us, and we did have a lot of success in multiple myeloma, launching 10 drugs as a foundation and really extending the lives of our patients. But we were hugely frustrated that we didn't have data, and we couldn't, way back when, get the academic centers to provide the data we wanted to find the targets for precision medicine. So we had to put all of that data out there. And even as we did that, and we were having this discussion in the green room, but even as we put all the data out there, what we realized was everybody was using the data. Any scientist can use this $40 million data set that we funded. A lot of it was just happening, at ASH and ASCO, and yet it wasn't changing what was going on with our patients. And it wasn't necessarily changing how we would identify and validate the best targets still that we needed to focus on in myeloma. So we ended up having another business philosophy where we had to put more funding out there and say, okay, now we want all of you to play and apply together to validate this target, to validate a high-risk signature. And you keep having to put money and project management into the pot to get everybody to keep coordinating behavior. And we're finally there, but I will tell you, it takes some heavy lifting. What we found was even though we put $40 million into a data set, it was hypothesis generating. It wasn't enough to validate. So even in our tiny cancer, I still need to go over to Lori Glimsher at Dana-Farber and say, you've got a great data set. Can I have that? By the way, could I give it to Colin Hill at GNS? And could he, because they're not going to hand me their data set at the MMRF. So what are the business models that will create that? I want data, I want to know the target, and how do we push forward? We've identified a lot of them in myeloma, so we know BRAF, we know FGFR3, and we've moved forward and done precision trials around all of those and made a lot of progress. But we still have a ways to go, and I think immune will be an entirely new space for us where we go, what data are we collecting, and how do we really start to do this well?
So, patients are heroes who say, take a piece of my tumor, or I'm even going to allow you to do another biopsy so you can actually look at the DNA. When patients do this, and then an academic investigator, this is my data set, it's my data, I want to use it, and I'm not going to let anybody else because my career depends on it. Should all data be liberated? Should all data be open source? It's the patient's data, after all.
I believe so, and I think you have to find ways to do that, because I get it, an academic center, this is their gold. Like they've put a fortune into it. But I do believe you can set up these situations where we set up one called the Answer Fund, which is you put the question out there. Another example we had was, Myeloma patients don't want to be on maintenance therapy. Payers don't want to pay for maintenance therapy.
So maintenance therapy is after they go into remission from chemo, you keep them on a drug.
Yeah, you keep them on the drug. And you could be, as a myeloma patient like myself, I was in a complete remission. I had no idea how long should I stay on maintenance therapy. Was it really required? And it's not fun to be on the drugs, and it's expensive to be on the drugs, but nobody knows the answer. So we realized by doing a crowd program with our patients, that was the #1 question they had. Now you've got to bring all these data sets back in together, because we didn't have enough data, again, to answer that question, because it's not necessarily like the pharmaceutical company wants to say, well, I don't want to need to have you on maintenance therapy anymore. So I think we have to come up with creative ways where data gets aggregated and data gets analyzed. And interestingly for us, we found that by going out to the machine learning companies and saying, this is the question we're trying to answer, can you help us and apply with the data set you know, then we could find out who was willing. And then if an academic center didn't necessarily wasn't part of that, then we go back to them directly and say, would you put your data set in to answer this question?
One thing just to interject here that I think is really interesting is that's two things that I think are going to change that a lot in the next few years, and have already started, is one is thanks to wearables and genomics. I think all of a sudden, it used to be that most of your health data was sitting in an EMR somewhere, and it's out. It used to be a filing cabinet. They put it online, call it an EMR, but it's still a filing cabinet when all said and done, and out of your reach. And I think now that's, between your genomic as well as kind of wearable data, all of a sudden there's a pretty heavy amount of data that's completely health data that's in control of, in the hands of consumers.
Yeah.
So along with consumerization of healthcare, I think, one thing that we've seen with color is like, everyone who takes a color test, we give them the option to contribute their data to research anonymously, and we get, in the like 70 to 80% opt-in rate. And I've heard that across a number of different services, so I think people are very willing to do it. And so, as these services become much more accessible, I think that's going to become just, standard practice. Like, I think it's going to be much more the exception.
Why are the 20% saying no?
I think for some people there's a fear of their data being misused. Obviously, every few months we'll have a story around privacy issues, whether it's in healthcare or in Equifax, et cetera. So I think there is a certain level of concern around, how much do you trust a company to make your data available? So I think that's probably one of the bigger hurdles. But I mean, the 80% is still, I think, huge value. So,
is data security something you guys are looking into on the health side?
Yeah, I mean, information security in general is an issue, and I think data security is generally handled very well in companies with a HIPAA and so on. So I think that part is not a concern. I think what's interesting is that patients can own their own data.
So HIPAA's not data security.
Yeah, that's true. I mean, so is data privacy. But I think when patients, so data security internally, I think is part of just information security in general. In terms of data security for patients, what's intriguing is that patients are allowed to have their own data. And then the question is, what do they choose to do with it? And are they informed such that they know what they want to do with it?
If I were running a color genomics, I would be awake all night thinking of what if a woman took the test and didn't understand the results? How do you know that someone is going to do the right thing or really understands it? And how do you sleep knowing that they may not?
Yeah, no, it's a great question. It's actually something that we spend a huge amount of time thinking about, and especially in these cases where you're fundamentally dealing with a statistical answer, right? You're and ensuring that people really understand what the information conveys, and for example, especially telling someone that they're a negative, making sure that they actually know that doesn't mean that they're not going to get cancer, and that they should, and so that's something we spend a huge amount of effort, on both on the comprehension, but also surveying people afterwards. That's also why we include genetic counseling with every color test as part of the service. And one thing that's kind of interesting as part of that too is that we actually almost I think half of our GC time is spent talking with doctors, educating doctors about this information, because now the majority of doctors who are using genetics today are no longer your cancer docs, right? You're starting to see many more OBs and GPs that are using this information, so ensuring that they understand what this information means and what the follow-ups, that follow-ups that should come out of it.
Yeah, we're not obviously trained in that. I want to go to questions in the audience because I want to kind of bring in everybody to the discussion. Yes. A mic is coming at you. Duck.
Valerie Montgomery Rice, Morehouse School of Medicine. And so, Ahmed, I would like for you to share a little bit more about how you move beyond just democratizing access from the cost, but what type of partnerships you've done. And I know one of them is with us, but with others to really make sure that these genetic tests are accessible to many other women.
So, thanks for the question. I mean, that's something that we spent a lot of time thinking about. I think one piece is, maybe I'd break it into like 3 big categories. One is kind of democratizing in terms of like relative to social, categories, whereas whether it's, in cases of minorities or, historically most of the people who had access to precision medicine were wealthier people, so kind of ensuring that, that there's an opportunity for access, across different levels. So one of the areas is working with, Morehouse and a number of other centers. I mean, so we have a program called we used to be called the Every Woman program, now it's called Color for All, but where we offer subsidized testing for larger populations. That's one category. Second one is around research. I think, historically, a lot of the scientific data that's used today is around essentially Caucasian populations. And I think there's a lot of value in incorporating into these large research data sets non-Caucasian populations. And so that's something that I think is quite interesting. And then the third part is thinking outside of the US. When you think about developing countries and, less wealthy countries, like you'll have, for example, if you look at Nigeria, I think literally there are fewer oncologists in the entire country of Nigeria than there are in San Francisco. And when you think about, a situation like that, the question is how are you going to deal with the burden of cancer or the burden of heart disease, as the population ages. And there, I think, really working with health systems around having a prevention first strategy that's less about waiting for people to be damaged to try to do something, as opposed to really using this information for prevention from day one. So I think those are kind of the big ones for us.
Thanks. We have another question.
I wanted to support what Kathy said about sharing data and how important that is. We do offer every single patient at Dana-Farber the opportunity to have their tumor sequenced. And about 85% of them say yes. And those data get deposited in a consortium of cancer centers. There are probably 15 of us now. And the reason that's important is, let's say a patient has a rare mutation. And there may only be 3 or 4 patients at Dana-Farber who have that mutation, but we can go into the database and find, well, maybe there's 5 people at Memorial Sloan Kettering or 3 people at MD Anderson. And together, when you put those patients together, now you have enough patients to do a small phase 1 clinical trial on a drug that's in development that targets that particular genetic mutation. And so I would just, second what Kathy said. It's critical to share these data.
Lori, why do 15% say no?
I think the same reason that was given to you earlier by one of the panelists. I think to some degree, it's a worry about privacy. It's a lack, perhaps, of understanding of what it means to share one's data, or a fear that that data will be used for purposes that are not consistent with that patient's beliefs. Yeah. We'd like to get it to be 100%. And having said that, it's very expensive because most of this is not reimbursed by insurance companies. Yeah. So we have to raise philanthropic funds in order to be able to offer this service to our patients.
And just to touch upon that a little bit more, we knew that Dana-Farber had a great data set for us because it was a competing data set, a competing trial with the one we were doing to sequence the genomes of all these myeloma patients. And so we knew that those were 2 good data sets because they weren't putting people in our study because they were similar. So that's where you want to combine it. But you can't just go to an academic center and say, can I have your data set? And I think that's the business model we learned, is you have to go to an academic center or whomever, frame a very specific question. And I also find that a lot of times by working with the machine learning companies, you learn. You can't just say, well, should we do maintenance therapy? There's 100 questions within that question. So you really have to work with a team to decide what data do you want, how do you bring it together, and who's going to spearhead the project. But I think over time, and going back to democratizing care, You know, in myeloma, what we would really love is to have a database so huge that no matter what your subtype was, any community oncologist could go into the data set we're building that is genomic, clinical, longitudinal, and structured, and be able to say, based on everyone before you and that subtype and everything they did, here's where the outcomes were better. And at least let the community see that, and at least democratize care so it doesn't matter where you are. Any community oncologist could figure that out.
That's great. Aligning incentives and obviously sharing data. We have a question. Yes.
Excellent panel. Really appreciate your comments. I'm Nina Shelson, an early stage venture capitalist with Canaan Partners. And in addition to the data access and sharing, never mind the plumbing that brings it all together from all the various different points of care, a couple other major bottlenecks that we see for precision medicine are access to medical geneticists as well as bioinformaticians. And I'm curious, particularly from Omran and Vijay, how you're solving for those issues and constraints.
Yeah, I mean, I've seen companies where they're attempting to scale these methods with, with telemedicine and approaches like that. I think it is a challenge, and I think compute can scale what we have, but can't create what we don't have. And my hope is that as the opportunities come with companies like Color, we'll start to see the opportunities for needing the genetic counselors as well.
One last question, quick. We have 1 minute.
Yep. Yeah, I'm Alan Sachs, Chief Scientist at Thermo Fisher Scientific. Kathy, at lunch today and again during this discussion, you've indicated if you could do it all over again, it sounds like you would have done something differently. Maybe expand on that a little bit?
I don't know. Looking historically, we started to build our own data set in myeloma when genomic sequencing was pretty high. So making a $40 million investment for that, I still think it was the right thing to do. One thing I might have done differently was when we actually built the whole data set out, we thought that we could build out a portal where all the scientists could be playing with it, and then we could build something out for the community, but two such very different needs, and we never got to the patient piece. So that's why we're really starting to work with new partners so we can say, build a huge data set, make it statistically significant, and create the plumbing and the hardware in a way that you can really create simple visualization for your academic scientists, for your community, and really for the patient as well, because we want to be getting them as engaged as we possibly can. But there's a lot of education that goes along with it. So I might have just done a few of those steps in parallel as opposed to the way we did it, because I feel like it's taking too long.
Well, thank you to the panelists. I want to say before we end is that, Othman put his money where his mouth is, or some expression like that. And each of you have a card for a free BRCA test. To truly democratize the test and give it to all of you. And hopefully you can spread the word about genetic testing, personalized medicine. The conversation will continue in the reception before dinner. But I thank each of you for participating, and we'll move on to the next panel. Thank you. Thank you. Healthcare has been resistant to change, and this industry needs to be disrupted probably more than any other industry. The World Health Organization ranks the United States 37th in health in the world, so we need disruptors. We have a panel coming forward now of people who are going to talk about new ways to address this. Doctors Jessica Mega, Brian Roberts, with the amazing Fortune writer Michal Lev-Ram. Thank you very much.
Number 37, woo! Jessica Mega is Chief Medical Officer with Verily, and Brian Roberts is a partner with Venrock. And yes, they are both doctors. I'm sorry I didn't put the doctor in front of
real
your name,
doctor, not real doctor.
Fake doctor.
Fake doctor.
Okay. So before we dig into the next big thing, I want you both to just very quickly give us a little bit of context into what you've been doing up until now. And so you've both been exposed to a lot of old big things, right? Brian, you've been doing this for, you've been in venture capital for about 20 years, and I read that you've seen, is it 25,000, I was gonna say 2,500, 25,000 pitches? That was your estimate, that you've been pitched 25,000 times.
Let's go with that.
You've gotten to see,
lots of them.
How many of those have you said no to?
All but about 20.
Yeah. Well, and of those 20, though, you've had how many? 9 of your portfolio companies have reached a valuation of $1 billion or more. So
yeah, can
not
take a
too
while.
bad. So just give us a little bit of context for sort of where you invest and the type of companies you've been investing in.
I tend to invest at the earliest stages of companies, really when they are a couple of interesting people going after what I consider to be an interesting problem. Usually it's a problem that is hopefully sizable and acute, and in some way newly tractable, right? So that you're not trying to land on Mars, but you're also not competing with 45 other people. Okay. And it's really that intersection across all of healthcare. So genomics, drugs, devices, software, services, delivery. It's really just the people and the problem.
Okay. Okay, Jessica, you've had a pretty amazing career in academia and research, and then you threw everything away and you went to Google. Why did you do that?
So I'm a cardiologist, and I absolutely love taking care of patients. I'm also, in the spirit of our panel earlier, a physician scientist, and I think that's something we share. I spent a lot of time thinking about what's the evidence that you need to really change patient care and improve outcomes. And what I saw looking at a company like Google X, and that was the company I joined, it was a group of engineers trying to take next generation tools and apply them to healthcare and life science. And for me, the critical moment was understanding that it's not going to be one person or one group or one organization who's really going to make the difference. It's going to be taking all sorts of people, including software engineers, hardware engineers, and physicians, along with many other people, including patients, to actually make a difference. So I packed up my bags and headed out to California.
Silicon Valley. Okay, and I think a lot of people probably want to know and are wondering, what does Verily actually do?
So Verily is the branch of Alphabet that focuses on life science and healthcare. And what we try to do is think about a big problem where new either hardware, software, analytics could make a big difference. And I'll give you an example. If you think about something like diabetes, and we know that this is an illness that is escalating, we've even heard multiple references to it today. We only are starting to understand what diabetes really is. Now that we have things like continuous glucose monitors that give us insights, not just a few blood sugars a day, but really what's going on at a deep pathobiologic level, my estimate is that we probably have many subtypes of diabetes. We just have been treating them all similarly because we haven't had that hardware. And I think the real beauty and where I'm most excited, and this is something Brian and I have talked a lot about, this idea of taking hardware, thinking about the information that's coming out of it, and it's not lost on me that we're sitting, this is an electrocardiogram behind us. But there's
just for you.
Thanks, guys. This idea that information streams everywhere is critically important. And so for a person with diabetes, if we can match the hardware, we can match the software.
I think your mic is off. We will get you a handheld if it doesn't come back on.
Handheld.
No, you're back.
There we go.
Excellent. Are we good?
Yeah.
Just don't move.
Okay, I'm not going to move because we're talking about high tech here. I'm just going to stay very still. So if we end up combining hardware and we take that information and we surface insights to patients, then we can start to make a difference. And so what Verily's focusing on is that intersection of how do you take these technologies and put them in the hands of patients and providers so that we can improve outcomes. And in some ways, it reminds me of what I did before. I'm just doing it in a new setting.
It's an interesting notion, right? Like, I think much of the future of healthcare is actually interdisciplinary and sort of full stack, right? You're going to have to, there's been lots, we've heard about it some today, there have been lots of sort of point solutions into healthcare, and the uptake and retention of those have been very hard. And so you now have, whether it's in the medicine side or the delivery side of healthcare, you've got people going after much more holistic solutions, right? So on the genomic side, you've got people not only doing wet lab stuff, but the software stuff on the back end, right, to give people answers. On healthcare delivery, you've got people not only developing a novel device, but actually getting it to market and taking care of the full spectrum of the patient journey. You've got pharma companies now not doing just pills and needles, but doing services and add-on things to grab on to the whole patient and try and provide actually outcomes, not just sell point solutions into things. And, you know, Verily sort of a piece of that whole journey.
And in light of that, I mean, we had somebody ask earlier, what's the role of big tech companies in all of this today? Has that changed? What do you think is the role today? I mean, do you at X have the upper hand here because you live and breathe data, right? And that's what it kind of comes down to, or is that not the case?
Go, Jess.
So we were part of Google X, and some people know Google X as the company that came up with the autonomous vehicle, or Waymo. There was a group focused on access and energy, and then we had a group thinking about healthcare and life science. We ended up spinning out to be an independent group because everyone in this room knows how big and important healthcare and life science is. It's also regulated in a very different way. And so trying to think about what are those conditions where we can make a difference and where can we apply analytics is really key to what we do. The other thing, though, and this is critical to our mission, is we believe in partnering. So there are many entities and ways that we're thinking about how do we get solutions to patients quicker. And I'll just give you one example. Earlier today, we were talking about electroceuticals. And there was a real push to say, if we could target peripheral nerves with very small electronics, could we change biology? And this is something where we bring a lot of the technology. We do have groups that have been working on very small biocompatible electronics for a long time. Mm-hmm. That generates a lot of data. We have groups that focus on that, but we partnered with GSK because they had been thinking about the underlying biology. So this intersection of biology and tech, I think, is going to be something to pay a lot of attention to.
Yeah, so the tech companies have stubbed their toes historically, just like think about the personal health record at Microsoft and at Google, like all sorts of places. And maybe Apple will succeed with the iPhone and the records on the iPhone. The place that's frankly most interesting to me about coming out of the big tech companies is in the voice rec and machine learning side of things. Mm-hmm. They're just pushing those technologies and capabilities so far, so fast, that they may get to a performance spec that you could then use in healthcare. And then there's a whole super wide set of interesting things you can do.
And just really tagging on that, it's this idea of what are we really trying to solve? And so I think the point you're making is that tech is one piece of this problem. And so if there's an area where image recognition is front and center, we can leverage a lot of the work that's already being done to sort images that you have on your phone every day. So that same sort of application is something that I think is going to make a big difference. I don't think in terms of putting my physician hat on, there is going to be a role for the physician and for patients working together. And I'm frequently in debates where people say, should I go into medicine? And for anyone who's a physician out there, I cannot imagine a better time to be an engaged physician thinking about how to bring these new tools to light.
You mentioned earlier big tech companies stubbing their toes in some previous attempts, which I know have been going on for years and years. What about startups? There aren't that many people that do what you do and that do it successfully, and I think your average time that you spend on boards is significantly longer than.
I wish.
Well, in good cases, I guess.
Sure.
What, 12? Yeah. More like 12 years versus 5 to 10.
Long time.
So, are those timelines shifting at all? Is it getting shorter as technology, like the kind that you're talking about, is more ubiquitous?
I don't think so. I don't think so. Look, I think, in all honesty, I think it takes a decade to build an interesting product, right? I think you can get lucky earlier. Certainly fail faster than that, right? But in frothy markets, you can be accorded value much faster than that. But to really create an enterprise class product that's got the complexity for something like healthcare, it takes a decade, right? And in drugs, it takes longer. Devices is plus or minus that much to get developed and through trials and launched. And on the software side, it takes about that long. And again, you start selling to bleeding edge development partners 2, 3, 4 years in. But in order to really create something meaningful, it takes a while.
What about for you? You're doing one of your big projects that you've taken on is this 5-year-long research project. Can you talk a little bit about that and you know, it's 5 years, so we know how long it is. I don't have to ask you about that, but
Well, it may actually go on even longer.
that's how they hooked you. They told me it's 5 years.
They told me 5 years, and then the teams. So the idea, much of what I was talking about earlier today, focused on problems that we have today where we have known solutions. So I mentioned diabetes, and the reason there's so many interventions in diabetes is that we know the relationship between glucose and having high levels and having poor outcomes for patients with diabetes. So you'll see all sorts of tools and interventions. And I think that's great. On the other hand, if I were to ask everyone in the room to raise their hand if they know anyone themselves or their families who are struggling with a certain medical condition where there's knowledge still to be known, I think we would have a lot of folks who would raise their hand. And so the idea of this study that we're doing is called Project Baseline. And what it is really going back to first principles, understanding what it means when you look at someone's genome, but also interacting with volunteers and asking them about their health. And then having physicians who are also engaged in terms of also getting devices. So it's the full suite of understanding health from first principles. And part of it, and this may not be obvious on the surface, part of it's even creating the infrastructure to understand everything that we've been talking about today. It's one thing to talk about looking at the genome and looking at health outcomes. It's another thing to actually have tools to do that. So we're on this mission. I hope to come back hopefully sooner than 5 years and be able to say that we've been able to see new biology so that folks in the room can start to create new tools to tackle new disease.
Do you, Google, or I should say Alphabet, the parent company, has a reputation for, you know, throwing things on the wall and seeing what sticks. This is kind of like a different area here when it comes to health, right? But do you care? Is the vision that this is going to result in money-making products for your parent company, or what is it?
Yeah, the idea, and I think Brian likely has a similar philosophy with the companies that he's involved in.
He wants them to make money, for sure.
We have the advantage of being able to see the long view in health. And so if you look at our portfolio, there are a number of projects that are going to deliver solutions in the near term. So near term, I mean the next few years. But for anyone who's spent time thinking about biology, we know that sometimes it takes a while. And when someone comes up and they say, wait, you haven't cured cancer yet. I'm like, no, not yet. It's going to take a while. But we are able to take a long view, which is also, I think, very advantageous when it comes to health and disease.
Okay, I want to go to you guys for questions. If anybody has a question or a comment, please raise your hand and a microphone will come to you. Somebody has to ask about the contact lenses, right? No questions. All right. Oh, there's one over there.
So Kathy Juicy, Lisa Boyette, CEO Curable. Kathy Juicy was just on the stage and mentioned the words project management. And now we're having a conversation about a bunch of technology, coming in at different points in the patient experience and whether we should be integrating those to have a holistic approach and really stacking things and delivering a whole solution to patients, maybe even patients where we don't know how to treat their disease yet. Whose job is that going to be? Because right now, I'm not sure that's anybody's job. We heard about the MMRF and how that was done for the group of diseases that make up multiple myeloma, but in the absence of the MMRF, I'm not sure we'd see the extension in survival time that we've seen for those cancers. And those are philanthropic dollars funding that work, and I'm just curious what your perspectives are on who's really going to do that integration and holistic delivery and how we'll fund that work.
So I thought I heard you talk sort of about two different things, so I just want to clarify for a sec. One is discovery of novel therapeutics, novel treatments for diseases, right, cancers. The other is integration of technologies for patient care on the patient journey. From my perspective, the latter one will sit purely in the hands of the primary care doc. Is that the part you were talking about, or did you want to talk about scientific medical discoveries?
I guess just having heard Kathy Juicy on the panel just prior to all of you and thinking about that group of diseases and how you started in a place where we didn't know what to do for those people and came such a long way in 15 years, that's everything. But just on the delivery end, I don't think most primary care docs really are getting an opportunity now to bring those amazing tools to their patients. You know, they're seeing more and more encounters every day. They're just vehicles for generating RVUs in most systems.
You want to go?
Yeah, you know, I think it is a critical question when I put on the hat both of someone who's had family members with illness and also taking care of patients. You're right. It is, and Kathy is probably one of the best champions to really say we've got to understand where people are coming from. One thing I have seen is technology is being able to link the inpatient experience with what's going on every day in a person's life. And so I do think there are tools that help with that project management aspect of it and hopefully empower the relationship, not for packing in, okay, I'm going to meet with my doc and I have to run through all of these questions, but really having much more availability. So I do see a number of solutions that are trying to think much more holistically. So I'm cautiously optimistic.
Question over here.
Yeah, well, it wasn't a question. I just wanted to address your question briefly as the
We
president.
can just leave now.
Okay.
As the president of a cancer hospital. So I do think it's the responsibility of tertiary medical centers to harness all these data and make sure that they get out to the community. 90% of oncology care could be delivered in the community because most cancers are not all that complicated. And so many cancer hospitals are in fact setting up satellites in communities staffed by their own physicians so that everybody has access to clinical trials, everybody has access to the latest drugs and therapeutics. But you're absolutely right. We're not getting all of these discoveries out to all people, and we have to work hard at that. And I do think it's the responsibility of the teaching hospitals to do that.
I have to confess I have a simplistic view of this, which is that a lot of the answers to much of this stuff sits at sort of the intersection of information availability and incentives. And the incentives have been very fragmented and very adverse across various parts of the ecosystem for a long time. But there's no point in changing incentives if you don't have the information to then do stuff. And there's no point in having all the information in the universe if the incentives still are pretty screwy. So I think it's at that intersection that you're going to see a bunch of stuff.
Another question back there?
Thank you. Thank you both for your questions, for your answers, excuse me. But my question's about the EMR. So as a machine learning company, you know, we exist because Cerner and Epic exist, but also they are not the easiest to work with. So just wondering, Brian, you know, is the EMR a lost cause, or, you know, what's your view there on that landscape?
You sound like device folks talking about Medtronic. It's all the same thing, right? Like you have a dominant player in a space who thinks that that they bring lots of that's true, Illumina and genomics, true. Like they're like, we're bringing all the value here. You know, everybody else is sort of secondary. I think that while all docs complain about their EMRs, I think that as a sort of a central repository for clinical information, I think they will continue to exist for a long time. Whether they will improve their user interfaces and a whole bunch of stuff like that, or they will be disrupted out of that, I don't know. But the disruption is going to be hard because you know, the harder something is to put in, the harder it is to take out, right? Like there's nobody who ever wants to go away from SAP, right? Because it was such a pain in the ass to put in. And I think the same thing's true of Epic.
How many years out do you think that is, a potential big disruption?
On the database layer, I think it's probably a decade out. Personally, I wouldn't go after the database layer, personally, right? I go after the intersection, I go after that last mile between the physicians and the database, because it's sort of untenable. Like physicians these days are spending all their patient encounter time typing into stuff, and then they're spending like 3 hours at night typing into stuff. And I ought to be able to be a doctor and sit in a patient encounter with you and have my discussion with you, right, be bringing stuff out of the clinical database to prompt me to ask you stuff, right? Like you ought to be able to get in and out of that in real time. That's stuff that's got to come.
Yeah, and I think that layer of the comment about the onus on sharing best practices. We can use the data that is in the database to disseminate decision support. There's also obviously academic medical centers that have a mission and a role there. The other piece I would say is if you think about current healthcare data, standard data will fit on about 5 to 7 CDs, for those of you who still use CDs. If you think about where data is going in the next decade or so, we're talking now about 15,000 CDs per person. So I think the Epics and the Cerns and a lot of the databases in the hospital are optimized for the work there, but there's a lot of other information, whether it's someone's genome, their proteome. The last panel really highlighted that. And how do we harness all of that information and apply analytics, which is what you're alluding to. So I think there's lots of different data streams, and the real challenge is figuring out an infrastructure that's going to be able to look across that and make data insights actionable. So that, to me, is where the world is going.
So real quick, because we do need to wrap up, but we obviously want more and more innovation, but how do we avoid another Theranos? What's your take on that?
Yeah, I think that we always want rigorous science. That's one thing that's come through the theme of everything we've done. So make sure that when people go into healthcare and life science, we look at the data, we have the right quality and regulatory systems in place, and we hold each other accountable.
Brian?
I don't think you're gonna. I think there'll be another one.
Yeah.
Like
Can we expect more transparency from, I mean?
Look, there were sort of two pieces to that puzzle in my mind. One was the fraud side, right? And like, let's be clear, like there's a whole industry, there's a whole audit industry to try and keep track of it. Fraud's hard to figure out. Like if someone really maliciously wants to, do stuff, for a while they can. The one that's sort of tougher to deal with is the people selling forward on too little, right? That whole sort of fake it till you make it, but then you never make it sort of thing. That's diligence. And from my perspective, it's investing in people who are truth-seeking, right? Who hold themselves to a higher standard and are harder on themselves in the outside world.
All right, I think that's easier said than done, but good words to end on. Thank you both so much.
Thank you.
I'll see you guys back out there in a minute. So before you all leave, just a few very, very quick announcements. We're going to be treated to an interview with Tony Robbins pretty soon, but first we're going to invite you to this evening's reception, which is being held on the Sunset Terrace. Immediately after the cocktail hour, we will return here to this room for the interview with Tony. After that, we will all proceed to dinner at the Dana Point Lawn. Bring your jackets. A quick reminder that our breakfast concurrent sessions will kick off tomorrow morning at 7:45 a.m. And then we have another action-packed day in store for you guys here. For early risers, you can also join our early morning meditation session with Ariana Huffington's sister, Agapi Stasinopoulos. That's at 7 a.m., and that's going to be located in the Eco Adventure Center in the lobby near the concierge. I didn't know the Ritz had an Eco Adventure Center. We will see you all shortly. Enjoy the reception. Thank you.
Wow, 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 wow. We are honored and grateful to be in our third year of collaboration with Fortune Brainstorm HEALTH's founding partner, IBM Watson Health. I can't tell you how important their partnership is to us. They've really been visionaries in this area, and we are so, so, so grateful. And to introduce tonight's guest speaker, please welcome my friend, the General Manager of IBM Watson Health, Deborah DeSanzo.
Thank you, Cliff. I can hear the Watson Health guys. So as Cliff said, this is the third year of IBM Fortune Health. It's also the third year of Watson Health. So we're very pleased to sponsor this again. And the reason we really want to sponsor this is, can you believe the visionaries that we've seen in the room today, from Bernard to Martine? Toby's here, Anita's here, Ariana, the whole group. And we think, you know, if we're going to make a difference in healthcare, you really need visionaries to do it, because visionaries fundamentally think differently. And I don't know another healthcare forum that brings together visionaries like Brainstorm Health does. So we're very pleased to be here. We have said from the beginning that if we want to transform health, no one company, no one NGO, no one research institute, no one provider, no one payer is going to do it alone. We really need to do it together. And also the conversations that you see happening in the hallways, during the breaks, really bringing people together is what will transform health if we keep it going. So don't let this just be an event where we get together here, but carry it on so we can really make a difference in healthcare. So with that, I want to introduce our guest speaker tonight. It is Tony Robbins, who really needs no introduction. He has spent his life overcoming challenges to become renowned globally for his ability to teach others how to persevere through tough times. Now, he doesn't know this, but in like 1998, I had a choice. I could either go to Unleash the Power Within in New Jersey, or I could go to the American Heart Association Heart Ball. And I really wanted to go to the American Association Heart Ball, but my husband said, no, you need to go to Unleash the Power Within. And it was unbelievably life-changing. It changed my life. I really think I'm here as the head of Watson Health because what I did 20 years ago. We went to everything, went to mastery, and so I think we are in for a terrific treat. So Tony owns, I didn't know this, he owns 33 companies totaling $5 billion in revenue, and of course is a #1 New York Times best-selling author. Tonight he's going to share more about his own journey through his personal upbringing and how he can teach anyone to believe in themselves. Now, he is being interviewed by our own Dr. David Agus, who, of course, is the professor of medicine and engineering at the University of Southern California and CEO of the Lawrence J. Ellison Institute for Transformational Medicine and our co-chair of Fortune Brainstorm Health. So I am very excited to see this. I have a front row seat right here. And with that, please, I want a big round of applause for Tony Robbins and Dr. Agus.
That's quite an introduction on you.
Yes, it is. Thank you. I think she gave me way too much credit for what she's done with her own life.
You created Watson. That's so amazing.
Isn't it amazing? I created the internet before that, so.
So, obviously, Tony, everybody knows about you. Presidents, CEOs, you name it, you come in, and there's something about you that changes them, and they get transfixed. Every day, you know, I can only imagine the stress you have that people are putting, you know, their trust in you. Does it stress you? Are you stressed?
I physically stress my body to extremes because I've developed a process to take people and help them change in a weekend, but my idea of a weekend is 50 hours, and most people want set for a 3-hour movie. So, you know, that somebody spent $300 million on, and I got 12,000 people in a stadium. I got back from last night up in San Jose. We had 4 days and nights like this. And we actually had a halter on me and a group of researchers that work with Olympic athletes, and I burned 9,500 calories in one day, in 9 hours. The battery died before I finished. I went 12 hours. I burned enough calories for 2 marathons. My jumps, because I'm jumping constantly, was the equivalent of 2 NBA games. My lactate, as you all know, at 1 is hard to talk. It was 14, and I was still going strong at 12 hours. So there's some physical stress because I'm a believer that talking is bullshit, that you gotta go deep. You gotta get people to experience things. I think a belief is a poor substitute for an experience. And if I get someone to experience changing something, if I can do it in a really potent way where they really feel it, then, if you do that over and again, you start to get someone to actually be trained to get a new result. It's not about belief. Belief is important. It's not about confidence. I heard that kind of description. It's never been what it's about. It's strategy. But if you don't have the certainty, you're not gonna execute. So I think I've spent a lifetime accumulating patterns. There are patterns we all have. There are patterns that make you angry, patterns that make you sad, patterns that make you excited, patterns that make you grateful, patterns in health, as you well know. So like all of you who are the best at what you do, I'm massively into pattern recognition, pattern utilization, and pattern creation. And those things help me to create changes that wouldn't have happened before. And I get the phone call when the athlete's burning down on national television, Serena Williams, I got to produce the result now. So I fly without a net, and that's part of why I got good, for 40 years. This is my 41st year doing this. I started when I was 3, of course. And then I also have the same thing where, you'll get a child that's suicidal. I've never lost a suicide, knock on wood. I'm sure I will someday, but out of thousands, and we make films. Because when people are going to kill themselves, they have a reason. They believe that dying is more painful than living. You shift that, they don't kill themselves. I get the phone call, true story, the President of the United States calls me, Clinton, and says, they're going to impeach me in the morning. What should I do? I'm 31 years old and I'm getting this phone call. It's like, could you call me sooner? That's the first part, right? So by doing deep practice, by practicing without a net, by putting in a situation, you've got to find a way. And because I really care, most times I've been able to find that way. And then that builds your own sense of certainty. And also, I put myself in enough crazy environments that I've had to adapt to so many things that there are only so many problems. And there are unlimited ways to change them as far as I'm concerned. So when someone who has more variability meets somebody with less variability, the one with the most variability will dominate and be able to help.
How do you turn off?
That's a great question. My wife is a huge part of it, my kids, my grandkids. But I don't feel stressed, so I'm not turning off. I certainly relax, I play squash, I read, I go to movies and do simple things, fun things. But my life is a mission. And so it isn't stressful for me, it's exciting for me. I can't wait to wake up in the morning and because we've worked together, I don't sleep a whole lot. I'm sleeping better. I got rid of the sleep apnea, which was very helpful. But I was sleeping then 4 hours a night, which is horrible. But most of my life, it's been 5 or 6 hours. And now I'm making myself sleep closer to 6 as much as I can based on, education, what sleep does.
You won't even remember this, but I met you about 15, 16 years ago. It was, I gave my first corporate speaking gig. And I was scared to death. I'd never done it before. It was in London. And I get there, and Liz Murdoch says, David, I'm so glad you're going to speak, but you're going to follow Tony Robbins. And I was like, what? And, watching you on stage, you are an athlete. Yes. In what you do, you engage people. 90% of the audience, like this kind of audience, didn't want to be engaged, and
Yes.
you're able to do it.
Yes.
The feedback loop has to be there. Are you watching every person and seeing, I have to amp it up, amp it down? Is there a feedback loop when you do this?
Of course. Everything is based, everything in my world is based on coming up with the outcome that will serve and then going at it. But most of the time, your approach going at it doesn't work. No one else knows that, but you can see it doesn't work. So it's constantly changing your approach until you can get where you want to go. When I enter an audience and I'm going to give a talk of any sort, I do a huge amount of homework in advance. I prepare, I see who's there. But then when I stand up here, I wouldn't be sitting like this. I'm scanning constantly. And who I'm looking for, the people think it's bullshit. I'm going after the people who got dragged there. I'm not looking for the people clapping for me. Those people will always be there, and there's some people who clap even if you're terrible, so you don't want to let other people's view make you feel good. I'm looking for who isn't there so that I can reach them, so I can show them that there's something real here. Because most people don't know who I am. They'd see 10,000 people jumping in a stadium and they go, oh, it's just a big motivational pump up. I've never been a motivator. It's never been what I've been about. I think motivation is useful. It's like a warm bath. You should probably take a bath or a shower every day, but you need more than that. You need strategy. But what I really believe is energy. Most of us grew up, and right now, most of you are learning in the traditional style you did even when you were in school. You were trained to go to your seat and be silent and be polite and nice. But the world we live in today isn't like that. The world today, if somebody sits down and waits for someone to tell them what to do, they're in trouble. So my approach is constantly stimulating and seeing what's real, getting people to be raw, and getting to truth. As corny as it is, the truth sets us free, and we all can find our own truth as long as we put ourselves in an environment where we don't tolerate anything less than that.
How do you know, how do you get better? How do you know, listen, I was good today, but I want to be great? What are the metrics you use? I mean, is there data you get back? How do you improve?
Well, we have all the social media data, which we use big data to take a look at, but I also look at it individually because there's nuances that you pick up in that way. So I feed that, look at that. But my biggest piece is watching the audience, and then, every day of my life, I get feedback. I'm walking down the street, a dozen people come and tell me these beautiful stories, how their life has changed. And very much like she shared earlier, they'll give me way too much credit. So I always straighten out and go, look, you did this. I'm glad I got to help. And I try to keep that balance with everybody. But my measurement is both emotional state impact as well as execution. Did they lose 20 pounds? Did they go turn their business around? My business is organized around, I really want to help people improve all the qualities, areas of their life, but there's about 7 that matter the most. It's your body, it's your emotions, it's your relationships, it's the way you manage time, it's finances, it's your work, and it's the spiritual side of life. And so what I spent my life doing is modeling people that are the best in the world. You find a couple who've been together for 65 years in their 80s, late 80s, and they're still making love and passionate, not just hanging out. They're not lucky, they're doing something different. So I'm constantly finding those patterns so that hopefully I can compress decades into days. I can learn from those decades of life experience, save it, bring the answer here to myself and others, and see a measurable impact.
And you like it, you enjoy it.
I don't have to work, fortunately, another day of my life, and haven't for 20 years almost. So I work harder today than I ever did when I had to. It's always been what I love. I've never done it for the money. I have lots of companies, that make me a lot of money, but it's not about the money for me. It's about changing lives, and when I was growing up, I went through a really tough childhood. My mom was a beautiful soul, but she abused prescription drugs and alcohol. And people have different personalities in that area. And I'm the oldest. I have a younger brother, 5, younger sister, 7 years younger. And she bashed my head against the wall. She'd think I was lying, and she pulled liquid soap down my throat till I threw up. It was pretty brutal. But it made me become a practical psychologist. It made me have to learn what makes people get crazy, get angry, get excited, get loved. And I had to learn how to manage her to protect my brother and sister, and to some extent myself. And so, if my mom had been the woman I'd hoped she'd been, I wouldn't be the man I'm proud to be. So it all worked out in a very beautiful way. But it made me, I had so much suffering in my life. I don't want any human to suffer. And I'm effing driven to end suffering wherever I can possibly make a difference. I don't want just end suffering. I want them to experience the joy and the happiness and the freedom and the love and the opportunity to live life on their terms.
But do you have to fail to be successful?
Yes.
Do you have to have suffering to be successful?
Well, you have to fail. I don't know if you have to suffer. The old phrase, pain is part of life, suffering's a choice, right? And I have and just in recent years, I've made a big change in that area of my life. Most of us, I think in the culture, this is a different room because people here, my guess is, I don't know you all personally, but you wouldn't be coming here figuring out how to be on the cutting edge, going next level if it was just a job for you or a career for you. You guys are in it to win it. You're in it to have an impact, is my guess for most of you. This is a mission drive for you. When it's that mission drive, it just gives you so much energy. You don't have to worry about, trying to pump yourself up or do something like that. I mean, this room doesn't need to be motivated. I've never been motivated anyway. What I really try to do is have people figure out what's their drive. I'm more the why guy than the motivator. I want to know why you do what you do. Motivation, I hate the term, but it's just what's your motive for action. And, I'm the why guy. I want to know why you say you want this, but you do the opposite. I want to know why you say you want to be fit, but then you go eat all that stuff. I want to know why your relationships aren't working the way you are. So if I can figure out the why and show you tools and strategies that are real that you can go implement and you see a result, and I can do that with tens of thousands, hundreds of thousands, millions of people, then I've made a contribution that feels meaningful to me.
If I met the 15-year-old Tony Robbins, would I have said, this is going to be a successful kid?
15, what grade is that? Let's see. So that'd be like junior high school, like 9th grade, is that right?
Yeah.
Well, I wanted to be a professional baseball player. The father who adopted me, I had 4 fathers. His name was Jim Robbins, was a pro baseball player.
Right.
And, but I started very late. I had tremendous desire and no effing skill. And I hated when we lost. I would cry. I was an emotional creature. So if you'd seen me at that time, when I got cut from I was a really smart student and I was really good in science. And the science teacher, I was really his pet, Mr. Gaze. He was also the coach of the baseball team. So I went out for pitcher and did really well. And he was a very strict guy and I had very long hair. So I got to the final cut, I cut all my hair, and then it didn't work. He cut me anyway, and I didn't make the team. So that kind of started me looking, and around that time, you might have, because I learned how to type. I took a typing class. I was the only guy in a shorthand class because I wanted to go interview. I wanted to become a sportscaster or a sports writer. I wanted to be in the environment. If I couldn't be the person in it, I wanted to be a part of it. And I got a job at a local newspaper, and then I was offered a job on KTTV Channel 11 in LA at 15 years old. Because they tried Fannie Fox, they tried everything to try and get people to pay attention to their sports forecasts. My mom took me out because she said my ego was too big and ended all of that. So you probably would have seen that he was this driven guy. I got an interview with Woody Hayes on, the night before the Rose Bowl, taking buses to Pasadena with my little brother with his Instamatic camera, taking pictures.
That's awesome.
I was driven. I've always had that drive. I've had to have that drive, or I wouldn't have survived.
What do you read for fun now?
I don't read for fun. I think I watch movies more for fun. For fun, I read Lucky Years.
All right.
There's so many hours in a day, and I'm so hungry for these things. And I'm involved with so many different industries, and now I'm involved with stem cells, with cellularity. We raised $250 million, and I've got unbelievable partners in Bob Harari and Peter Diamandis and so forth. So I'm on the edge of those things. I've been a beneficiary of those things. So I look at subject matters that go in that area, but the fun part for me is really play golf, swim, snorkel, scuba dive, do all the things that are more physical outdoor are the things that get me there, and they're part of how I really relax. I'm like, I push myself to a different extreme, so I relax, I think is probably.
And are you an extreme exerciser? When you snorkel, do you go, is it really pushing yourself?
No, I used to only do that. I used to have only one gear, not anymore. But when I do exercise, I'm a biohacker. I find the very best tools that produce the most intensive, and that's why I have these guys out to measure everything on me, right? So they're going to come up with a plan that helps me to demand even more. I'm 58 years old. My body operates, I'm able to get it to do things better than I was when I was 25. But there is the accumulation, as you well know, of living a life with that kind of intensity for 58 years. And so I'm using every tool that I can find. I haven't gone to CRISPR yet, but I've done just about everything else you can imagine. Cryotherapy I utilize. Obviously I do stem cells outside the country, so I get cord stem cells because they're so much more powerful than the adipose or the bone marrow. So those are all things that I kind of do to keep myself in that place.
And do you self-educate on these things?
I do, but I wrote a book 5-6 years ago. I got so frustrated. I hadn't written a book in 20 years. I don't like writing books. I like new. I like it's different every time. I like the challenge of something showing up, and sitting and writing was not my gig. But I also have coached some of the top financial traders in the history of the world. Paul Tudor Jones I've coached for 22 years, and heads the Robin Hood Foundation, some people will be familiar with in New York. And he's just a brilliant, incredible man. And he hasn't lost money in all those years that I've coached him. I literally coach him every day in writing, but then I see him 4 times a year. And so I decided I wanted to write a book. And so the way I wrote the book was, I said, I'm going to interview 50 of the smartest financial people on the face of the earth. Warren Buffett, Carl Icahn, Ray Dalio, just the whole 9 yards. And so that's what I do. I go in and I'm really good at modeling. I'm good at digging in and finding out the differences that make the differences and extracting them from someone who's got more experience than anyone else on earth. So I wrote that book under the goal of...
That's Unshakable.
Well, I wrote a second book called Unshakable after, a smaller one. My first one was 670 pages, the first book I'd written forever. I wanted my billionaire clients to actually say it was valuable.
You do things. It's pretty...
Yes, I did. I wanted my billionaire clients to love it, but I wanted the general population, someone who's just getting started, to be helped by it. And Paul Tudor Jones, is one of my dearest friends, laughed and said, Tony, that ain't gonna happen. But it did. Another magazine, I won't mention the name, said that it was a book that if there had been a Pulitzer Prize for financial book, this one would win hands down. So then I wrote Unshakable, a skinnier book, because I realized somebody's going to be intimidated by it, and I wanted to get it out before the markets changed to kind of help people. But the reason I tell you that is I'm doing the same thing now in the health field. I'm going to write a new book similar to what yours is. You're one of the people I want to interview for it. All the people that are here, I want to go and dig underneath and bring that to the general population so that they're aware of it. And I have a style of communicating that's good for some people, so I want to try and get that to millions of people. Plus, I've donated, all the money from my books. I've fed 300 million people in the last 3 years alone. And so in Feeding America, I was fed when I was 11. On Thanksgiving, I had no money and no food, and a man came to the door, and he was the delivery man. He wasn't the actual one giving it to us. And it changed my life. My dad was offended, but I was like, wow, strangers do care. And it changed my life, made me care about strangers. So when I turned 17, I fed 2 families. It was really emotional and beautiful. And then 4, and then 8, and then I got to 1 million people, and 2 million, and then I got my foundation feeding 2 million, and I mirrored it with 2 million. And then I was writing this book, interviewing all these billionaires, and watching them cut food stamps. They don't call it that anymore, but the same thing, SNAP program. They cut it by, I think it was $7 billion, which means if there's someone out there that really needs help, a family, a mom, struggling single mom, and they don't have food, and there's 49 million Americans that don't know where their next meal's coming from, in the richest country in the world, just makes me nuts. I wanted to make sure that I could have an impact on them. So I found out I fed 42 million people in my life, and I said, what if we fed 50 million people in a year? And then I got more excited, it's at 100 million. And now what I'm doing is I'm feeding 1 billion people over 7 years. So we fed 300 million, 100 million a year for the last 3 years. And it's all, again, come out of that. So I'll write this book and I'll donate all these to some of the things I'm doing on the health side as well.
That's amazing. That's amazing. So obviously, you're brilliant. What you do changes the world. You give back. You grew up with very little, and then all of a sudden, you amassed wealth.
Yes.
What was the first luxury item you bought? What was the first thing you did for yourself?
I think probably buying a car of some sort. I was a boy. Boys think cars are everything, and they're the boys. So yeah, I bought a Mercedes, I think, and then I was so stupid. I grew up very poor, so these were symbols to me. I got my office in Beverly Hills and all that bullshit. You just have to, when you don't have something, you think that's going to make the change. But what was beautiful is I knew from the very earliest stages, I had a good teacher, and he taught me a long time ago that, what you get will never make you happy. Who you become, that'll make you very happy or very sad. And so my whole focus is be a blessing every day on the lives of anybody I meet. I'm fortunate enough now I can walk by, and some people feel like it's a blessing because of celebrity, whatever the hell that is, but taking a picture or light somebody up, but really helping somebody, somebody that's suicidal or somebody that's, help them turn their business around. And I get to work with people that are hungry. People ask me all the time, what's the common denominator? Because, you got a Mark Benioff or, Ray Dalio, all these superstar geniuses that are followers of my work. And then you got the average person just getting started. The extremes are pretty huge. And the common denominators, I see people when they're hungry. So people are the best in the world are always reaching out because they know one little 2 millimeter shift and you can end up in a completely different direction over time. And so they're hungry. They haven't lost their hunger. It's why they're the best in the world. So I get all the best. And then I also get people when they're at a position of challenge, because that's when people actually start to pay attention, just like they do in health, right? They should have taken care of it all along the way, but now there's a crisis, and now they're willing to do something. And they've tried everything else, so they'll try the crazy guy with the big teeth from TV. So that's something like that usually.
All right. So you've got 4 decades left when we start to look at actuarial tables.
Yes. Wow, I'm glad to hear that.
I don't believe in triple digits. So in these next 4 decades.
I got 40, so you're counting on being 98.
So is your lifestyle sustainable? Can you keep doing what you do? I mean, I've seen you do it. There's no way you can sustain this for decades more, I don't think.
Well, they told me that, I went to Harvard because my throat was just, I finally thrashed it completely. And I went to a doctor, a really brilliant man. He deals with Steven Tyler and all those guys, the best in the business. And he asked me how long I spoke for. And I said, well, the average day is 12 hours. And he laughed like you did and didn't take me serious. He goes, no, really, how long? And I said, well, the shortest day is usually 9 or 10 hours, and the long ones are 14. And he said, people in the room. I said, yeah, for 3 or 4 days in a row, sometimes 7 days in a row. And he said, that's impossible. So he goes in to look and puts a scope inside me, and they numb you up. And then he goes, no. And I'm like, and he leaves me with the thing down my throat and brings 2 more doctors, and they're all talking about that's not possible. So afterwards he came out, he goes, you've done something that medical textbooks would say is physiologically impossible. I've done this 38 years, never seen it. He said, your vocal cords are the size, they're supposed to be the size of your lips, and they're the thickness of your lips, and they're the thickness of a piece of paper. He said, there's no way you should be able to talk. You got to the point where you couldn't speak, and the reason I talk and sound this tone, whatever you hear, is because I've found a way neurologically to fuse my false voice box to my normal voice box. He said, I've never seen it in my entire history, and he goes, that's how you're talking. So I'm not suggesting I'm bulletproof by any stretch. I think you know I've reached out to you. I just spent 2 days in New York with a doctor doing a battery of tests. I was just at Forward. Where's this Forward here?
Is Adrian?
Is Adrian in the room here? I was at Forward in San Francisco. Oh, there he is. In San Francisco, and I was in your place in LA today. I went through the full piece. And, I'm scoring in the top, 0.0001% psychologically and physically, so I'm still good. But the answer to your question is, I still need to be smart. I work to balance my life, but it's not draining me. The only place it hurts is too much lactic acid or too much of those things, and that's why I'm doing the things I'm measuring now. I think with technology, I can measure things, and if there's a challenge, I want to handle it when it's small, kill the monster while it's little, not wait till it's big, as I know you teach.
So, the biggest challenge, or one of the biggest challenges we face in health is how do you get someone to do something today that's going to help them 10, 20, 30, 40 years out?
Yes.
Right? That delay, in disease,
yes,
in a sense, hurts us, right? There's no metric. I can't take a blood test and goes, you have a score of 100 or a score of 98. There's no metric for health.
Yes.
So how do we in our business and the people in the audience who have that issue all the days with their companies and their products, how do we get people to change today for tomorrow?
Whatever we do, I think you probably know, what we do is shaped by two things moment to moment. Because what we all in this room are influencers. What's a leader? Your job as a doctor, I would assume, or running a company is to lead. To lead is to influence. And I think influence really, or leadership really, is the ability to influence thoughts, feelings, emotions, and actions of another human being, and then do it with integrity, meaning for their greater good, not for yours, being like a fiduciary. And all doctors are, and all financial people are. So I look at that and I say, the biggest difference that you can make is learning how to change your client's state, whether it be your clients being your employees or whether clients being, a patient that's in front of you. Because the mental, emotional state we're in does everything. If you're in a pissed off, frustrated state, your biochemistry, as you well know, 5 minutes of rage and your immune system's suppressed for 5 hours, right? But I also found, I know that statistic, that I can do a stacking of positive emotion and shift somebody and have them 5 hours where they don't even know why they feel good during those pieces. So I look at the ways we can change state. And the way I found to do it, and I've taught for 41 years, is physiology first. The way we move determines the way we feel. And so you can't influence somebody else if you can't even influence yourself. Very often you'll see leaders who are in a crappy state and they're trying to lead somebody else. You can't do that. You can't get someone to do something you're not doing. You can't get someone to feel what you don't feel. You can't touch someone if you're not touched. You can't move somebody if you're not moved. So the first thing is your state. And really training yourself to measure it. Because just like medicine or anything else, or business, you can't manage something if you don't measure it. So I measure 0 to 10, where am I throughout the day? And it's not like I have to be a 10 every moment, but I know where I need to be in order to produce the greatest result. And then I know how to change them. And the most simple thing in this short moments we have here, and by the way, I pride myself on adding value. I only have 30 minutes, and he's asking me about my life, which doesn't mean shit to you. And so I want to serve any way I can any of you. So when we're done here, if any of you go to my website, I'll give you an address. And if you ever want to come to an event as my guest, I'd love to do it, because I'd love to add real value to you, not just 2 minutes like this. And I'm also appreciative that I was invited. Thank you very much. But in short order, emotion is created by motion. And what you're really talking about is compliance for people taking their pills, following all these things. It's all based on the emotional state they're in. So people have habits of emotional states. And so what I try to do is uncover what are the patterns that are in front of me right now. So for example, if we all in this room said there was a depressed person behind curtain number 1 over here, and I'll make a $100,000 donation to your favorite charity, if you could describe them physically, you could. What's their posture like? Yell it out if you would, please. Slumped. Where's their head? Down. Breathing full or shallow? Talking slow or fast? Loud or quiet? Now, how do you know that? Because you've practiced a scrap before, haven't you? We all have, right, at times. But if you take that same person whose shoulders down, all these things, and you don't change, most people try to change the mind. I'm happy, I'm happy, I'm happy, and BS, you're not happy. Your brain knows that, right? But when you change the body radically, you change the biochemistry, the state changes, and they make a shift. So for years, I've taught people movement, sounds, elements to do this. Professional athletes. I just worked with the Warriors. They're in bad shape. I guess KD's going to be here tomorrow.
He's
coming
coming tomorrow.
because he's injured, right? But I just work with.
He's got nothing else to do, so he's coming here.
But they called me in because Steve Kerr's injured. He's been injured for 3 years. The team's injured. They're back in second place. They're not where they want to be. But what do I got to do? I've got to come in, and these guys have the skill. They've lost the state. Katie says, it was weird, I don't have Steph there. And he's busting his tail playing like crazy, but the team wasn't winning. So what I got to do, I got to come in and change the momentum. And the first place I change the momentum is physically in their states, because they all walk in, they're basketball players, and they're coming to a meeting with a coach, and you know what that is. You don't look at him, and you don't talk, you look at the ground, and that ain't gonna do shit. So I got to come in and grab them. And so I find the ways to grab them, make them laugh their tails off, challenge them, bring a guy on stage, shift him right then and there. But I use physiology as the base and then focus. Because what you focus on, you feel. If you're supposed to be with your husband or wife or boyfriend or girlfriend, meet them at 7 for dinner, you get there at 7, they're not there, what do you feel? Some people go angry, some people worried, it's just 7. What if it's 8:30 and they've not called or texted and you're there? Woman says, I'm full, I'm not waiting for the bastard anymore, right? But most people, they make up a story, right? And if you're focusing on you're mad, it's because they always do this, they don't care, they're probably screwing around with somebody else. If you were worried, you pictured them in a car accident. So I show people quickly how to change those states. And once people learn how to do that, it becomes addictive. Because they know that I'm not a victim. I don't have to wonder, do I feel good or not? I don't wake up in the morning every morning and go, wow, let's go kill it. I wake up some days and go, what country am I in? What city am I in? I got 3 hours sleep, my back hurts. But I know how to shift that to step up and deliver, and I really believe that's made a difference also why I've lasted so long, because I put myself in states where my body can put itself back in balance and heal, even though I'm making huge demands on it. And then, by the way, to answer your earlier question, I do a whole series of regimens to recover after these things. I don't just presuppose that it's all just going to come together, right?
Has the current president called you for advice yet?
No, I bet you're surprised to hear that he hasn't. He's always asking people for advice, isn't he? I know the current president pretty well. I gave him his first big speech. Unfortunately or fortunately, depending upon your point of view, I guess. He came to do a speech. I hired him, and I had a multi-speaker event I was doing, and somewhere in his head, he figured there was 200 or 300 people there, and we had 15,000. And he freaked out. He really freaked out. In those days, he wouldn't even shake anybody's hand. He was so worried about, getting some kind of bacteria on him. And but he got hooked, and he did the entire speech on, get a prenup. That was his entire speech.
Really?
That was the key to success, was get a prenup, of which. But, he was on that show, and people wanted to come hear him, it was there. So, no, I know him well. I know Hillary well. I know President Clinton well. I know, I've worked with all the living presidents. So they're all friends, and his communication style is one of the most difficult things that we all have to deal with. His actions are tough, but I think his communication style is part of the bigger challenge.
Is there a person in the world that you want to meet that you haven't met yet? Is there somebody out there who...
Hello. There's no one in particular at this stage of my life. I've every major entertainer, politician, business person. But when I hear about somebody that's brilliant, I seek them out.
Any popes?
Yeah, I'm meeting the Pope in a month, actually.
Seriously?
Yeah. We're going there for the. I'm sure some of you may be there. They have the annual conference that they have on regenerative medicine. So because of our stem cell company, I'm going and I'm meeting the Pope, and then I'm speaking. I'm the last speaker in the regenerative conference there.
Oh, that's great.
Yeah.
So, as we conclude tonight, you have a group of healthcare executives, leaders in the health space. This is a group that has had ups and downs in our field. And, Affordable Care Act, yay, now we're, peeling back from it. Drug pricing, we get a lot of bashing in our field.
Yes.
At the same time, this is the hope for all of us. Yes. We need all the people in the audience to be successful for us to live long and well, et cetera. So how do we change the mood in our space? We've got the government knocking us down. We've got legislation here. We've got the people thinking pharmaceutical companies are bad. Healthcare companies are there to take our data or charge us too much. How do we change the mood?
Well, I don't think it's just medicine that's going through that mood right now. And I think everybody can see that, right? Every kind of movement that you see out there, we have come to a place where we no longer seem to find a middle road, where everybody is either agrees with you or they're evil. If you look at things like all the issues, take outside medicine, say the safety and security of our children, there's nobody out there that doesn't want their kids safe. And yet we fight with each other as if the other side's evil because one thinks we should have guns and one thinks we shouldn't. So I don't know that there's a simple solution for what you're talking about, but in your space, there is a solution, and it is you first. It's like, you get on an airplane, what's the first thing they say? If we get into trouble, mask will come down, oxygen's there, and the first thing you gotta do is put it on your kid, right? No, why? Who do they tell you to put it on? Yourself, you selfish bastard. What's the deal here, right? But it's because if we don't take care of ourselves, we can't care of them. So for leaders, what I always tell them is, it's you first. It starts with you, and it starts with your psychology. 80% of growing a business, if you look at what the chokehold is on a business, it's always the leader. And 80% of that chokehold is the psychology, and 20% is the mechanics. I mean, people in this room know the mechanics and strategies beyond what anybody on earth knows in their category. So it's really about you being in the state where you execute. It's like I always tell people, knowledge is not power, it's total BS. Knowledge is potential power. Execution trumps knowledge every day of the week, and so my life is, how do you get yourself to execute? And execution comes from learning to put yourself in that right state every day. The second thing is not allowing, and I've only learned this in the last 2.5 years myself. I look at life as having 2 master skills if you want life on your terms, whatever your terms are. Change the world, have a beautiful family, have a great business, laugh a lot, sing, whatever your terms are. You need to master the science of achievement, which most of the people in this room have done a hell of a job over, they wouldn't be in the room, including you and me. And then there's the art of fulfillment. And the art of fulfillment sounds boring as hell because people say, well, show me how to achieve and I'll be fulfilled. But I interviewed 50 billionaires and about 12 are really good friends of mine now. And I could tell you honestly that 2 are really happy people. And it has nothing to do with the money. Money doesn't change you. I always tell people, if you're mean, you have more to be mean with a lot of money. If you're, generous, you have more to be generous with. Money doesn't change people, it just magnifies their nature. And so if you really want to change your life, the fulfillment part's important. I mean, I give you a metaphor. I feel like we lost a national treasure about 3.5 years ago. It came in the form of a man that used to make us laugh. What was his name? Robin Williams. And you think about Robin Williams, how many of you, I'm curious in this room, by a show of hands if you would, how many of you, don't raise your hand if you liked Robin Williams, raise your hand if you loved him, only if you loved him, if you loved Robin Williams. Keep your hands up so I can see if you look around the room. If you keep your hands up, look around the room. It's about 98% that love this man. Only 2% assholes that didn't like Robin Williams.
Yeah.
But the reason I bring this up is Robin was a super achiever. I mean, he came to Hollywood and said, I'm gonna be a star, I'm on my own TV show. Everybody says that. He did it. He said, I'm gonna have the #1 TV show. Some of you are old enough to remember Mark and Mindy, right? Me too. And then he said, I wanna have a magnificent family. Then he said, I wanna make more money than I could spend. He did all those things, he achieved it all. Then he said, screw that, I wanna make movies. Then he said, I want to not make movies, I want to make movies and I want to win an Academy Award for not being funny, his #1 skill, and he did it. And then he hung himself. Now, you can all say, yeah, but his brain was disturbed and we know he had the Lewy bodies in his brain. But let's be honest, he abused drugs and alcohol his entire life, and the reason was he made everybody happy except himself. My advice at the personal level is, find out what really fulfills you, and you will not hurt for energy if you can tap into that. But what will really fulfill you, if you haven't already found it, my guess is you have, or you wouldn't be in a room like this, but you could augment it, because you can get familiar with it. What really will unleash you is when you feel like your life has a meaning beyond yourself. I mean, when we have something that we're doing beyond ourselves, that's where the energy comes from. On a business side or a hospital side, David Feinberg's a friend of mine, used to run UCLA's medical schools, and he was a psychologist. He ran the little psychological center they had over there, and they had this hole, and they needed somebody right now, so they bring David in, and when they bring him in, he told me point blank, he said, Tony, I didn't know 3/4 what they're saying. Everything's an abbreviation in the hospitals, like the military, and they'd say, we need some SYZ, somebody, and he said, I had no clue what they're talking about. So I said, what'd you do? And this is the advice I give you as well, real quick. He said, what I did is I spent 3 months saying, I'm gonna learn everything I can about what people need and what they're mad about and what they want. And he did that, most importantly, with patients, but he also did it with a group. And I'll just give you 2 things to end. I know we gotta go.
Because I'm getting screamed at.
I see it, I can feel it. But I think this might be useful. I hope you'll hear me.
Yes.
He created a culture. He set a target, a vision bigger than himself, and he said, our goal here is to heal, and we're not. And here's how I know we're not. 29% of the people would recommend the UCLA hospital system to other people, which means 71% would not even recommend it, right? Which most hospitals, as you well know, do not have real high service ratings. He said, I want to get a higher service rating here at UCLA hospital system than they have at the Ritz-Carlton, and he succeeded. with 3 million patients, with 4 hospitals, and with 50,000 doctors who are not all in alignment, as you might guess, right? How did he do it? He did it by figuring out what the problems were. He didn't just focus on the medicine problems. He focused on the people problems and the process problems. He focused on the little stuff that really heals people and makes them feel at home and alive. And so little things, people being interrupted at 2 in the morning, at 10 at night after a surgery, and somebody's taking a trash can and food. But I'll give you 2 brief examples, we're done. One, he had an experience, this will be how he created the culture. He had an experience where a woman came in for gallbladder surgery and somebody did something wrong, messed up. They got the gallbladder out perfectly, but she got poisoned in the process, and instead of overnight, she was there for 6 days. Her husband brought her, he had to fly overseas for work. She leaves, she thought she was gonna die. She leaves, goes and doesn't have any money on her. Her husband's not there. She goes to the taxi place where they're supposed to give you a taxi piece, and they said, no, ma'am, you don't qualify, you have too much money. So she has like $14, she hires a taxi, he drives her within 3 miles of her house and dumps her. Right after she's in the hospital, she walks home. David finds out about this as the CEO of one of the largest hospitals in the world and personally drives to the woman's house, knocks on her door, asks to come in, apologizes, connects with her personally, said, I can never take away the fear and the pain you went through, and certainly make sure you didn't have to pay for it, but would you come with me back to UCLA and tell your story so I can bring all the doctors, all the nurses, everybody on the table, and show them what this means so they have an emotional association to what this consequence is. The impact of that is they changed, like, I forget the language you guys would all know, the mainline IVs that people die from very often. They got that number down to the lowest number, so low that the government came in and thought they were lying about the number, and he taught other people as well. One last example, woman's dying of breast cancer, terminal breast cancer at UCLA. She's 67, 68 years old, if I remember correctly. And they find out that her daughter is about to have this grandmother's granddaughter at San Francisco at UCSF. David said, we are here to heal, and here's what we do. We do whatever it takes. You treat people like they're your mother. That's what he did. So the gallbladder thing, because the doctor said, I took the gallbladder out perfectly. What are you talking about? He ran into this all the time. He said, it's not enough to do the medicine. You got to heal the people. You got to create an environment. You got to treat them like they're your mother. And once they started installing that, they started changing things. What this nurse did, she called up to UCSF, had the woman flown down, the daughter flown down, had her have the baby right there while the grandmother got to hold her granddaughter, and 4 days later she died. To me, that's what medicine should be about in the world we're in today.
Well, Tony, all I can say is and I think everyone in the audience is so excited for your healthcare book. We need it. We thank you for sharing your wisdom, your words, your love with all of us. Tony's been very generous in that there's a website that'll be placed up here where you can go there and he will send you a copy of Unshakable, his most recent New York Times #1 best-selling book. And we thank you for what you do for the world. We appreciate it.
Thank you very much. Thank you, buddy. Appreciate it.
Dinner now is on the Dana Point lawn. We will see you on the lawn for a great dinner.
The train is running.